this hospital. First, I just want to apologize and let everyone know that in recent events, we had to cancel because of what's going on. And for everyone's safety, this is why we were doing a webinar. But we had 240 people signed up for this event today. So truly apologize for that, but thank you to everyone who was here. I would ask everyone to please silence your phones because this will be broadcasted on a webinar. So can we please just do that a little bit? I'm going to bring up here Harold Rapp. Harold Rapp is a national recording artist, actually, and a good friend of mine. He is going to open us up with a national anthem here, and we'll go from there. Can we all stand, please? All right. Our first presentation today will be from Dr. Jason Stonebeck. Dr. Stonebeck is one of our orthopedic surgeons here. He is the head of ortho, and he is the program director for the limb restoration program that we have here at university. So please welcome Dr. Stonebeck.
Thank you.
Welcome.
All right. Is this on?
That's flashing.
Okay. This is on. Can everyone hear me? Fantastic. All right. Well, thank you for the opportunity to speak today. We want to talk a little bit about how we are changing the way we manage traumatic amputees. We have here, I'm the director of our limb restoration program, which is a multidisciplinary team that tackles patients that have limb-threatening conditions, including traumatic amputations, and we specialize in trying to keep the patient as functional as possible, which may be doing innovative techniques to keep the knee, which is important, and prevent above-knee amputation, all the way to some more innovative techniques that I'm going to talk about today. So today, I'd like everyone to understand the history and origin of what the topic I'm going to speak today about, which is osseointegration. Appreciate the preoperative, operative, and postoperative rehabilitation principles that go along with this surgical procedure, and identify patients that may benefit from this surgical procedure, as well as the various conditions that may preclude patients from being candidates for this. So I want to start this presentation by telling you a story about a patient that was referred to us who we'll call Mike. When he was 15 years old, he began having pain, and pain primarily at night that was waking him up. And ultimately, when he was diagnosed with osteosarcoma. So it was a tumor of his leg, which ultimately required amputation. Fast forward to when he's 22 years old, and he's cancer-free, which is a big win. He's functioning as an above-knee amputee, but he should be out, like this picture, having fun with his friends, doing things, right? But that's not where he's at. Currently, he tells me whenever I have a patient come in and who's having trouble as an amputee and looking at this technique that we're going to talk about today, I ask them, what do you expect to get from osseointegration? And he said, I want to improve my relationships. And I thought that was pretty powerful. I said, what do you mean by that? He said, well, when my friends call or when people I meet call and say, hey, would you like to do this or that, or go out to dinner, or go do some activity, do I tell them I'm afraid, I would like to, but I'm not going to go because I'm afraid my leg's going to fall off? Because that happens to him frequently and it's embarrassing? Or do I say, I'm busy, thanks for calling, but I just have other plans? Pretty profound story from a young man that should be out living life to its fullest. Another patient of ours is named Donna. When she was 31, she was involved in a serious motor vehicle crash, had horrendous bony injuries, and required multiple surgical procedures. Ultimately, had 5 knee replacements performed at other hospitals where it just wasn't working, okay? And she ultimately underwent an amputation. So now, fast forward 55 years of age. So here she is, and in this video, she's an above-knee amputee, obviously, and she's describing to us what it's like to be an above-knee amputee. So she's telling us you have to put on this liner, and it takes a lot of energy, and she doesn't know how she's going to do this when she's older because her fingers are tired, and as she ages, it's harder and harder to do. Then she feels the distal end, and the skin's folded up in there, and so she can't put on her prosthesis that way, so she has to start all over. Then as she puts her socket on, it digs into her ischium, or the backside, and her groin area, and causes pain that's constant all day long. The more activity she does, the more worn out she is, and even just sitting with friends or family at dinner, she has to sit on this large socket, and it's very uncomfortable, and all she can think of is, when is dinner going to be over so I can get this leg off? So, again, we're the limb restoration team, which is a limb salvage service. We don't like that term because it's about restoring patients' form and function, and that includes amputees who are having difficulty with an existing amputation. Our team deals with a multitude of problems, but we also specialize in the specialized treatment of amputees. Amputee care is a dedicated component of our program, everything from limb sparing type surgical procedures to research that we're participating as well as with at CSU in partial canine limb amputees and looking at very individualized and personalized care for the amputee, especially the traumatic amputee. So what are the issues with traditional sockets? So we know that, first of all, this is been a growing patient population with the recent wars and IEDs. But I think a lot of people don't know that less than 50% of amputees tend to return to work, and on average it takes them greater than a year to do so. Over 90% of bilateral above-knee amputees, because of how much energy it takes to get around and get up and walk, they're confined to a wheelchair. It can be a devastating condition, really impact your function and quality of life. Some of the issues that patients have, especially in trauma, burns, severe soft tissue injuries, and very short residual limbs, either below or above knee, they have a real difficult time getting good prosthetic fit. The traditional sockets that patients wear, they have a lot of pistoning and may have developed wounds and have a lot of pain and discomfort and wound breakdown from these traditional sockets. Additionally, they have poor proprioception, so they're unable to feel where their limb is in space at any time. So they have a decreased walking confidence, and just think about wading through a small crowd at a bar, going to the bar to get a drink. They have to focus on the ground, can't look up, and it's difficult to navigate those spaces often. So osseointegration is taking the socket part of traditional socket on the left and then anchoring it in a biologic fashion to the patient's skeleton. So this is truly like cyborg type of surgery, where we're putting a limb and integrating it into their skeleton. And this comes from actually dental implants, technology that was developed in the 1950s. So what they discovered was that titanium-based implants, bone can actually grow into this material. So the procedure, they would remove the bad tooth, implant this screw-type device into the mouth, cover the gums over the implant, allow that implant to osseointegrate or bone to heal into the screw, and then they would open the soft tissues and attach the prosthesis, in this case is a tooth. So Dr. Brannemark developed that technology, and his son in Sweden then took that technology and took it to the amputee. So this paper showed there was after 55 transfemoral amputations, there was a 92% survival rate at 2 years. There are some superficial skin infections that were much more prevalent early on, but then we've learned to decrease that over time by special techniques and implant design modifications. As time has gone on, these patients were followed, and then at 5-year follow-up, still a 92% cumulative fixture survival rate. 4 fixtures had to be removed, but there was significant improvement in the patient's quality of life. Huge. About that time, Dr. Aschoff in Germany developed a different design, which is a press-fit technique, which is where orthopedic surgeons use very frequently to implant total hip arthroplasties or hip replacements. This had the original design, actually to the left here, actually had this outrigger device to try to stabilize it, and had a lot of soft tissue issues, infection, and a high failure rate. The original design tried to incorporate the skin to get it to heal around the end of the residual limb, and that also had a lot of problems. So there was frequent issues like this where just the skin didn't adequately incorporate and caused a lot of problems. So over time, the design was made more smooth, and you can see this is more of the present day type of implant that we utilize. And with that, this is Dr. Aschoff and myself when I was in Hanover with him. He is a plastic surgeon by trade and has done a lot of innovation in how we treat the soft tissues. And here you can see a person had their soft tissue envelope revised so that now it's a very stable soft tissue envelope. And once we get a nice, stable soft tissue envelope, we're able to have a really healthy skin penetration site where the metal is coming out. Also, over time, we've learned that less soft tissue around this chronically open area where the implant is protruding from the bone, the better. Going from more redundant soft tissue on the left side to less on the right, and this significantly improved outcomes and decreased soft tissue irritation and infection. So this, you can see this left-hand column soft tissue and late infections dropped significantly with the modification in the design and as well as how we treated the soft tissues. So this early technology was actually utilized in other areas: facial reconstruction, fingers, dental implants, as we discussed, and then obviously with the amputees. So osseointegration, as I've described, is the process by which bone or the osseous tissue integrates into the implant. It's only being done in a few centers in the world, and it has primarily been done in the most numbers in Europe and Australia. Walter Reed Medical Center has been piloting, has the greatest numbers that have been piloted in the U.S. With the screw fixation type component. But here's the real benefit. So here on the left here is a above knee amputee. So they're in this socket, and as they put weight, they have unopposed muscle pull, which causes the bone to abduct, and basically when they put weight down, it makes their femur hit the side of this hard socket. It can be incredibly painful, cause wound breakdown, and be very debilitating. Once we osseointegrate someone, we correct, and I'm sorry it's cut off a little bit, but we correct their alignment so that when they put normal weight, it's going through the foot as it should be. So there's been various implant designs that are being developed. Again, this is a very new technique that we're pioneering. We've also noticed that amputees who wear traditional sockets aren't using their skeleton, so we're not loading that bone, so they get osteoporosis or thinning of the bone with time. And when we osseointegrate them, they actually will build some of that bone back. Huge. It's a huge game changer for patients' quality of life. Okay. Here's a study that showed 22 transfemoral amputees with an average age of 46, and this paper looked at the QTFA, prosthetic use, 6-meter walk test, timed up and go. How long does it take this patient to put their prosthesis on, get up and go, as well as O2 consumption, or how much metabolic demand does it require to ambulate. And so when looking at all of these scores universally, there's a huge, and again, sorry, it's cut off, but a increase in all of these measures which are positive for amputees. So they have a statistically significant improved overall quality of life, how much they use their prosthesis, how fast they can walk, how quickly they can get up and walk, and decrease in how much oxygen or metabolic demand, how much energy it takes to ambulate as an amputee. So other benefits to osseointegration, I spoke previously about when a patient wears a socket. As they're putting weight into their socket, there's pistoning. So they put weight and they may settle in their socket until they feel a firm end. Or there's not a real sense of security. They don't know where their foot is in space. But when you osseointegrate a patient, they can actually have what's called osseoperception, where they're able to feel vibration and how much force they are putting through their limb and where it is in space. So patients have actually had their dog lick their prosthetic limb, and they can, not looking, know that their dog licked their limb because they can feel that sensation. They can tell the difference between carpet underneath them or loose gravel. It's incredibly powerful. They know if they're actually stepping on your foot with their prosthetic limb. So this leads to increased mobility and function and improved function. And we know that in the diabetic and peripheral vascular disease patient population, when we perform amputations on them and decrease their ability to get around and exercise and be active, that actually decreases their life expectancy. So while this is not currently indicated or open to all diabetics and those with peripheral vascular disease, there are some patients that could benefit from this. But we try not to do that in those patient populations, but our research lab is currently looking at how do we make this more available to those patient populations so that we can actually improve their life expectancy. So we increase quality of life, and there's also some early research. There's this phenomenon called phantom limb pain that patients can get when we amputate a limb and they have limb loss. Their brain is still programmed that their limb is still there. So they actually can feel like their foot is on fire even though it's not there, or that something's itching it or hurting. And we've found that when we osseointegrate someone, their brain may feel like their limb is back, and they're getting feedback, like I discussed, through the phenomenon of osseoperception. And then through that, may have decreased phantom limb pain and other issues as a result of this procedure. So currently, this technology is being offered to traumatic amputees and those who are amputees from tumors. We hope to be able to make this available to the patients with diabetes and amputations secondary to peripheral vascular disease, but there's more research required in that area for sure. And the reason that patient population will be important is that diabetics are 8 to 24 times more likely to undergo an amputation than a non-diabetic. So it's that diabetic patients, along with peripheral vascular disease patients, make up the vast majority of amputees. This is a trauma conference, so we do this for trauma here for certain individuals who have failed traditional socket use, but I just wanted to mention that. So one of the oldest technology that was developed here is the screw type implant, and this is the original implant that was developed based off the dental technology, where this screw is screwed into the bone and then is left for a period of time until it osseointegrates, and then through the second stage there's a connection to the outside skin. This was developed by Dr. Brannemark, who was just here this week with me doing some surgeries from Sweden. We were doing the Corona handshake here in this picture that we're all becoming familiar with. The other type of implant is the press-fit implant, and this is sort of what that looks like. It's more of a rod type device that is impacted into the bone and creates a press-fit or a tight seal where it expands the bone, and then the bone gradually grows in over time. Then there's various connections that during the second part of the surgical procedure. Something wrong? Okay. During the second part of the surgical procedure, there's the connection to the outside world, if you will, is made through the creation of that skin penetration site. So here's a short movie of what the procedure looks like. There are two ways to do this. One is with a two-stage technique, and then there's a single-stage technique where we do everything at once. The most well-studied technique in transfemoral amputees or above-knee amputees is a two-stage technique. So an existing amputee, you go in, you open their residual limb, ream out the inside, and then place one of the two types of devices into the inside of the bone. Okay, this is a press-fit type device, and then the skin is closed over it and allowed to heal. With the press-fit technique, we wait about 6 weeks for the bone to integrate, let the wound heal, and then come back for an outpatient procedure, which is called stage 2, where we make a small opening in the skin and then attach several connectors so that we can connect the osseo-integrated bone implant to the outside world and ultimately the socket prosthesis. And this is what it looks like. No socket, no shrinkers, none of that. So these patients have to go through an extensive screening protocol where we have a pre-screening questionnaire. We want to make sure that they have reasonable expectations for the surgical procedure. This is not for everyone. This is for patients who are already having socket-related issues and not functioning very well with their traditional socket prosthesis. And we want to make sure they understand the goals, which is to improve their quality of life, get rid of the socket-related issues that they've been having. And we don't recommend this for patients who are, expecting to perform extreme sports like rodeo or base jumping or something like that. So it's for the person who wants to function in their daily life better and is having difficulty with traditional socket wear. The major inclusion criteria is you have to be skeletally mature, so you can't be a young child that's still growing. You have to have difficulty with the traditional socket use and be traumatic or tumor-related amputee. We do both transfemoral and tibial amputees here at this institution at the University of Colorado, and also have the capability to do transhumeral amputees as well. Major exclusion criteria are any comorbidities that affect bone healing, like immunosuppression or metabolic bone diseases, use of tobacco products is contraindicated, and then peripheral vascular disease. So when these patients come to be evaluated, they're evaluated in a multidisciplinary team format where they meet our surgical team that's headed up by myself, as well as our physical medicine and rehabilitation amputee specialists and prosthetists and physical therapists. And then we also have patients who've undergone this procedure, give them advice and answer questions that only a person who went from a socket to osseointegrated amputee can answer for these patients. Then ultimately, once they're approved for surgery, there's a lot of surgical planning that goes on. They frequently have severe traumatic wounds that have to be addressed, abnormal bone and complex anatomy is often the case, and may have neuromas or other issues with their previously severed nerves. Excuse me. So during a two-stage femoral surgery, the first stage is revision of that residual limb and insertion of the intramedullary implant. They're usually in the hospital 2 to 3 days and then go home for physical therapy for about a 6-week period of time. So here's a surgery that I performed actually when I was in overseas, learning the technique. We're revising the distal residual limb, and we take away excess soft tissue and muscle that's not needed. Then ultimately, we size the inside of the bone and prepare the intramedullary canal for insertion of the actual implant itself. We also reattach the muscles to the end of the bone so that the patient has good control of their residual limb. If you leave the muscles unattached, then they don't have quite as much control of their residual limb. They call it myodesis. After the myodesis is performed, we insert the implant in this manner, and this is the press fit technique. Then there's a lot of soft tissue shaping and contouring that occurs in order to make sure that they have a good skin penetration site with decreased risk of infection and problems with that we've learned over time from other colleagues. So this is just removing excess muscle and skin and subcutaneous tissue. Ultimately, we bring that soft tissue over the top of things and close the wound, and then allow 6 weeks of healing. After 6 weeks, the implant is osseointegrated. They come for an outpatient surgery where we create the stoma, or the actual skin penetration site for the metal that will be sticking out and available for attachment of the prosthesis. It's an outpatient procedure, pretty quick, and they start therapy literally that week. This is how that looks. Make a small hole. This is a metal connector called a dual cone that goes inside with a screw and is inserted in Once the implant is brought through the skin, we clean things out. It's taking too long. So once they have stage 2, we wait several days, and then they begin rehabilitation. Transtibial is often done in a single stage because they don't have as much soft tissue, but the procedure is basically what I've described previously all in one. So the patients have revision of their amputation, insertion of the implant. It's brought out through the skin, and then they stay in the hospital several days. We allow time for the implant to osseointegrate, and then they begin physical therapy. And so that's how the surgical procedure looks here. In a tibia, this person had a lot of difficulty with a very short residual limb, was having trouble having an adequate socket fit. Procedure is very much the same. This is a custom-made implant for this patient for their anatomy that's press-fit into the patient. The skin is then brought over with the stoma creation occurring and insertion of the percutaneous devices. And this is what it looks like post-operatively with dressings on. So what does it look like when we're done? So here's a transtibial amputee. So you can see they're just clipping on their limb. Much different than putting on an assortment of socks and different liners and sockets. This next video in the middle is one of our patients walking with her socket. She has a very abnormal gait. It's very painful while she's walking. Difficult for her to turn around. She has to widen her gait out abnormally and to make sure she doesn't fall, and then limp back towards us. This on the right is a patient who's been osseointegrated. So she has no socket. Her gait is much better. She can feel how much pressure she's putting on the ground. She can wear high heels. And that is just her skin right there. There's no socket or any sort of liner or anything. So here's some of our patients, what they look like preoperatively in a socket after stage 1. This is same day outpatient surgery stage 2. And then this is what they look like today, what Donna looks like today. And she's doing great, loves it, is very happy. Here she is undergoing rehab. Here's another patient of ours who had a more traditional deformity in her socket where she has abducted and flexed and having lots of pain from hitting the side of her socket. Once we've osseointegrated, we have normalized her anatomy, and these flexion contractures and abduction contractures tend to stretch out over time until they have a very normal gait and normal, and they actually will build muscle in their thigh and hips as they begin walking. Here's our first 5 patients during their first rehab with our team. Here's one of our patients post-operatively. You can see the metal coming straight out of her skin. Here she is clipping on her prosthesis. Much, much easier. She's able to stand without any difficulty at all, just like before she was an amputee. Post-operative gait pattern, one of our patients. He sachets because he's having such a good time. Here's a, this person was shot. So she was a trauma patient, was shot in her leg, resulted in a traumatic amputation from the gunshot wound, had to have skin grafting procedures and flaps in order to close and save her below-knee amputation. She had severe pain, constant wound breakdown from the skin grafts, and just had a real difficult time. So we osseointegrated her, revised her soft tissue envelope, and now she's, here you can see her radiographs on the left, and this is early in her rehab where she just has a soft dressing on, but she hadn't worn a socket for probably 9 months prior to this because she just wasn't able to after multiple failed socket attempts. So we're in partnership with multiple institutions around the world trying to bring this to the United States in a concerted fashion, and we're very excited about that. Our research lab is looking at how we can incorporate this technology into diabetics and those with peripheral vascular disease, and looking at clinical trials to make this readily available for all patients in the United States. And some of the exciting future directions are how we can harness the own patient's neural network that's been amputated and reconnect that in a meaningful way to their prosthesis. So there's a technique called regenerative peripheral nerve interfaces, where we take the amputated nerves and bury them in muscle that then creates an amplifier, if you will, that we can then harness those amplified signals from the existing nerves and use them to run myoelectric prosthetics. So patients often really like a myoelectric prosthesis, and when they get it, but it's a socket, and then it's very heavy, and they think it's great, but then they ultimately winds up on their shelf because it's just too heavy. But now that we're able to attach this heavier robotic arm to the skeleton, it's no longer too heavy to wear, and it could be a real game changer from the development of myoelectric prosthetics, including lower extremity. So here you can see some robotic ankle that we can potentially integrate into the patient's neural network. These are the things we're working on. So in summary, this innovative new technique started with the dental industry, and there are two options now. Infections can occur, but we're decreasing that over time and constantly improving things with further research and changes in clinical treatment. And it significantly improves their quality of life, but there's lots of opportunity for more research, innovation, and improvement. And again, couldn't do any of this work without our big team at the University of Colorado Limb Restoration Program. And thank you for your time. Any questions?
Is this on? Okay. We have some questions from the people that are watching remotely.
Okay.
One of the questions from Martha is there an effect on bone marrow and erythropoiesis from the implant?
It's hard to hear you. Could you speak up a little bit? Or
Is there an effect on bone marrow and erythropoiesis from the implant?
No. So while the intramedullary canal must be prepared in order to implant any of these implants, either the screw, they're globally called bone-anchored prosthesis. We have to prepare the canal, but we frequently harvest that bone marrow for healing of fractures that are difficult to heal, and for other techniques. The majority of that erythropoiesis is coming from your pelvis.
Okay. Another question is, will this be available for people who had amputations from non-diabetic related infections?
Yes. So those patients, we have a protocol for assuring that infection has been eradicated, and some patients may have an active infection. Once we've eradicated the infection, then they can be a candidate for osseointegration.
Okay. Does the impact from running deteriorate the implant over time?
Impact from running?
Yes.
So that's not a recommendation to run or do high impact activities, but there are lots of patients that have, we have videos, and there's been lots of patients who are out there doing things like running and jumping and things like that. While we don't recommend it, it has been done, but there's no literature that says that we can't do it. We just don't recommend it.
Okay, and I think the last question is, can this be done for patients who were amputees as children and then are now in their 20s?
Absolutely, yes. So we have done that for patients who had amputations when they were younger.
Okay.
All right, well, thank you very much for your time.
All right, everyone. Our next presenter is going to be David. David is one of our neuro ICU charge nurses and also the manager of the mobile stroke unit here at University Hospital. So he's going to come to you and talk to you guys actually about LVO or large vessel occlusion and how to recognize that in patients and what we do here at University Hospital for treatment for that stuff. And just a heads up in regards to what Dr. Stormbeck was talking about, if you are in a hospital setting and you guys are somewhere far out and you want to get this patient transferred to a location that does this, our systems transfer center, UC Health Doc Line, takes these calls, and we have a whole pathway process that we do to bring these patients here and activate this team. So just consider that every hospital in the state and surrounding states knows how to reach these providers because this is what we specialize in. Okay, guys?
Cool. Good to go. Can you guys hear me okay? Awesome. Yeah, thanks for having me and for the opportunity to come and talk about our mobile stroke unit here at UC Health and kind of go over some of the future states and some of the cool new innovations that we're trying out as well. So. Again, my name is David Ornelas. I'm the program manager for our mobile stroke unit. So we have the region's only mobile stroke unit, the only one in Colorado. We operate in 2 regions currently. So up here at UC Health in the Aurora area, and then also down in Colorado Springs out of Memorial as well. So we'll kind of go over some of the details of that and kind of what that means. So we'll talk about defining a mobile stroke unit. What is it? Kind of the advent of them, where we are now, how stroke impacts the U.S., and how do you implement one of these mobile stroke units and the benefit of them, and then identify these early outcomes. And then, as Daryl mentioned, we're going to go over some large vessel occlusion, the screening tools, some of the benefits, pros and cons, and kind of what the future state of identifying these large vessel occlusions is for the pre-hospital EMS setting. So kind of our why, why have a mobile stroke unit? Why have a, very prominent stroke program? So it's the 5th leading cause of death when we're looking at stroke and the disease. It's the leading cause of disability, however. So we're getting better at, people not dying from a stroke, but it's still taking people away from their jobs, their home lives, from getting back out into the public and doing what they normally do. Just some other stats there on stroke, how often they happen, and it's very prominent, and it happens very commonly. The number that we like to focus on is that bottom number. It's estimated that $80 billion is the annual expense for stroke and stroke care. So when we look at that, it's, do you have to quit your job because you're not able to go out and, participate and do your job? Also, we look at things like, does your loved one now have to, drop down to part-time or quit their job? Do you have outstanding medical bills? And is somebody having to come into your home and kind of take care of you in that state? So $80 billion is a huge deficit. It's a huge cost. So what we're looking at with our mobile stroke unit is if we are able to take this care to the patient and get them care faster, are they having to have less and less expenses from their stroke, less residual symptoms? They're able to walk out of the hospital as opposed to being wheeled out in a wheelchair. So we're hoping that our contributions to the stroke disease has decreased some of that, and we'll kind of go into the research studies and things that are out there for that. All right, so what is a mobile stroke unit? If you look at it from the outside, it looks like just a regular ambulance, but actually inside is kind of where the magic happens. It's a very specialized ambulance with a very specialized crew. And I have a short video here that will kind of highlight some of that, and then we'll dive into some of the specifics. Oh. Yeah, volume. Sorry, guys. Do you have volume, Daryl, for like a video? All right. Sorry, guys. All right. Got the expert coming. No, sorry, I forgot to tell you.
Yeah.
Playing around. Okay. All right, thanks. All right. There we go.
I was at work, break time was about a little after 6, and I started to get up. When I did, something just didn't feel right. So I worked my way back up to the supervisor, and I pointed to my right arm, and she dialed 911 instantly.
The treatment for stroke is really time sensitive, and so the more quickly we're able to treat patients who are having a stroke, the better they are likely to do. The Mobile Stroke Treatment Unit is a specialized ambulance with emergency stroke care to help the EMS crew that's on scene. We can evaluate a patient for a stroke and begin treatment right there on board. It saves valuable minutes in bringing stroke care to the communities we serve. There's a CT scanner. There's a UC Health telehealth connection to a dedicated stroke team at one of our comprehensive stroke centers. We also carry a clot buster called IVTPA on board, which allows us to begin treatment immediately.
With such a time-sensitive medical emergency, the Mobile Stroke Unit is an essential part of providing good customer service and a positive outcome to these medical emergencies.
Our relationship with the Mobile Stroke Treatment Unit is a seamless professional partnership where we provide the best outcome for our patient in a quick manner.
The quickness of stroke care makes all the difference. We can change the story for many patients and their families.
I got all the treatment I needed right there on board a stroke unit, and by getting to me so quickly, I have no lasting effects from my stroke. I'm back at work. My 4 grandchildren all live here, and I still volunteer for after-school sports and reading programs. I have no limitations, no deficits. The Mobile Stroke Unit is a lifesaver. Life is good.
So that's an actual patient of ours from down in Colorado Springs. He volunteered to be part of our promotional video, but he was having a very massive stroke, and we were able to provide treatment with him very quickly on scene and get him to the appropriate facility where they could do some higher level interventions that aren't offered everywhere. So I think that both of those coupled together helped increase his outcomes and increase his ability to get back and obviously hang out with his grandkids and kind of function back at work and become normal. So as you saw from that video, not just a regular ambulance inside. One of the biggest things that separates us apart is obviously our mobile CT scanner. So when we're looking at strokes, there's 2 different kinds. There's an ischemic stroke, which is a blood clot stroke. So it's interrupting blood flow, it's starving the brain from oxygen, nutrients, red blood cells. And then there's a hemorrhagic stroke. So that's where one of those blood vessels ruptures in your head. Blood is now spilling into brain tissue or around the brain tissue and not getting where it's supposed to be. So again, downstream, no blood, no oxygen, no nutrients. So the only way for us to be able to tell what's actually going on inside the head, inside the brain, is to do a CAT scan. We need to get a picture inside. We need to figure out what's going on, and that's going to determine our treatment pathway. So without this mobile scanner, we would not be able to identify this and figure out what's actually going on. So mobile scanner is able to help us determine which pathway to take. And then the other thing is we have a telehealth connection. So as you can see in that right picture, there is a telehealth monitor. So we're basically FaceTiming with our physician during the duration of the call. So they're able to see everything that we are in the back of the ambulance. The camera is very, very high tech. It can zoom in, see the patient's pupils, do a 280-degree view of the truck, so can see everything that we are, dialogue with us, and make sure that we're doing the right thing for these patients. The other thing that separates us is obviously if we have this CT scanner and we can figure out what kind of stroke we think you're having, well, what do we do from there? Well, we're bringing treatment to the patient. So we're kind of flipping traditional EMS for stroke care kind of on a 180. As opposed to the patient having to come to the hospital for care, we're now basically taking a mini ER, in a sense, to the patient. So onboard medications. We have what's called TPA. As Dr. Jones mentioned in that video, it's a very, very potent clot-busting medication. So if you have that ischemic stroke where that blood clot is going and plugging up that vessel, we're able to give you this medication, and it seeks out that blood clot, starts breaking it down, and then restores blood flow to the brain. So we start to see those stroke signs and symptoms reverse very, very quickly. On the flip side of that, if we have a patient who has a hemorrhagic stroke, so blood vessel ruptures, they're now bleeding into their brain, what's the way that we can stop that? Well, we have Kcentra. It's a medication that acts kind of in the opposite of TPA, and it helps to create clotting factors. So it can actually stop the bleeding or slow the bleeding from happening, thereby decreasing the amount of damage that's done inside the brain from that. So we have these two medications that are generally reserved for in the hospital setting, in the emergency room setting, and we're able to bring them to the patient. We are a fully licensed ALS rig. So just like any traditional ambulance that would come to an emergency, we have all medications needed for CPR, airway, anything like that. So if something does happen to kind of go south, as we say in the rig, we're able to accommodate and take care of those things as well. So why have a mobile stroke unit? So what is the benefit? Like we went over some of those stats before. What we're trying to do is see, are we able to do what's best for our patients in the community? We know that treating strokes quicker and faster helps improve those outcomes. So that's what we're hoping to do and determine is we're bringing this treatment to the patient. So are we improving those outcomes as well? We participate in national research trial right now. It's called the Best MSU study. So around the world, there's about 20 mobile stroke units. Nationwide, we have about 12. And there's about 8 of us that are currently participating in this research study. And what we're trying to do is we're trying to figure out, obviously we can bring care faster because we're bringing it to the patient, right? So if somebody's having a stroke, we're treating them in their driveway, Sprouts parking lot, King Soopers, on the side of the highway. We're bringing that treatment to the patient. But what we want to know is that making a difference? Are we doing something for these patients? So we're trying to see if treated faster, are their outcomes better? So just like that gentleman in the video, he was treated quickly. He was brought to the correct hospital, and now he's walked out 3 days later, and he's back with his family doing his normal activities of daily living. So if the outcomes are better and people are walking out as opposed to being wheeled out, we want to know, does this decrease healthcare utilization? So like I said, $80 billion a year is projected to double in the next 10 years. So we're talking $160 billion that stroke is costing the United States. So we want to know is, if care is received faster, if their outcomes are better, are we doing anything to that financial burden for stroke by utilizing a mobile stroke unit? So we are actually set to hopefully end our research study enrollment in late spring, early summer. And then we are compiling all that data and then hopefully publish shortly thereafter and hopefully prove that, not only are we bringing care faster, but it is making a difference. So that's kind of what we're hoping to do. One of the cool things is at the International Stroke Conference just this past month in February, our colleagues out in Germany, who were the first mobile stroke unit in the world, they ran a very similar study out there, and they published their data. And what they're showing was that patients were getting TPA stroke treatment around 30 to 40 minutes faster than traditional EMS and emergency room routes. And also what they're showing is that their outcomes are better and they're decreasing that healthcare utilization. So it was a very, very huge and powerful study for those of us in the mobile stroke world, and we're hoping that our study can, only replicate that. And afterwards, hopefully we start seeing more and more mobile stroke units pop up and kind of be implemented in different surrounding cities because they are beneficial and they are making an impact. So when we have a mobile stroke unit, how do we integrate it into traditional EMS? How do we get activated? Those are some of the big questions. So we actually worked very, very closely with our EMS partners. So here in Aurora, we have Aurora Fire. Aurora Fire Rescue is our main fire department, and then also Falck Ambulance for patient transfers. So before, the unit even got built or the idea was being conceived, we worked with them to figure out, how do we best implement this so that way, everybody's happy, we're playing well together, and we're doing what's best for our patients. So everybody went to the drawing board. We had all of the input, and we kind of got this up and running. We're going on our 4th year currently, so we have been a pretty big staple in the communities, both up here in Aurora and Colorado Springs, with the EMS system. So we get dispatched simultaneously with EMS. So somebody calls 911, says grandma's not acting right, she's not moving her right side. The dispatchers then code it out as a potential stroke. They send the alert to the fire department. It also gets sent to us as well on the mobile stroke unit. So in tandem, we are both going lights and sirens to this patient. And once on scene, we're able to evaluate together to find out, is this actually a true potential stroke, or is this one of the mimics? So is this a diabetic issue, or did this person just have a seizure? So there's a lot of things that, strokes look like but actually aren't. And once we get on scene with fire and EMS, we're able to kind of tease that out and make sure that we're treating patients correctly. We can also be requested by fire. So we have the, the radios that we're always listening to, making sure that we're listening to, are we being requested for something as well. And then we'll go over our rendezvous request. So currently our mobile stroke unit is the only mobile stroke unit in the nation that does a rural rendezvous. So we partnered with our EMS providers in the I-70 corridor. So these very small communities that, maybe they wouldn't have the opportunity to receive TPA. Maybe they would be out of that TPA treatment window. We're actually driving and meeting them halfway with their patients and treating them right on the side of I-70. So we'll go over some a pretty good case review on that as well. But that's some of the ways that we get activated with a mobile stroke unit. And like I said, on scene, we evaluate in tandem and make sure that these patients meet the qualifications for receiving treatment for their stroke. Because we want to do what's best for the patient at all times. We want to make sure that they are a good candidate, that we're not going to do more harm than good, and also that we're not potentially increasing that time frame from them to get to treatment. So a lot of things are in place for that, and we do really well with our EMS partners in making sure this happens. So one of the things that's been kind of in the discussion for EMS is destination. So where do we take these patients? The way that we determine it on our mobile stroke unit is just like traditional EMS, patient request. So if a family has a family member, loved one has is very adamant about going to a specific facility, well, we, by law, have to take them to that facility. The other thing that we can do is provide education on what type of stroke we think they're having, the size of the stroke we think they're having, and then the appropriate destination as well. So there's 2 different main types of stroke centers that we'll talk about today. First is going to be primary, and the second is comprehensive. So generally, I like to poll the audience to see kind of who could tell me the difference between the 2. But given our current state, we'll kind of obviously bypass any of that for right now. But a primary stroke center is a facility that is able to handle and accommodate stroke care by giving those treatments that we talked about, either that TPA or that K-Centra treatment. But they're not able to accommodate very large strokes. They don't have any of the bigger diagnostics that are needed. They don't have what we call interventional radiology, and we'll go over some of what that means, pictures, diagrams, and things like that. And these patients generally have to be transported a second time from these primary locations to our other type of facility, which is called a comprehensive stroke center. So comprehensive stroke center is all-encompassing. It's able to take care of the biggest, the nastiest, multiple strokes at one time from multiple people. So they're able to take care of all of those things all at one time in 24 hours, 7 days a week. So like I mentioned, Primary Stroke Center, it's a certification by our Joint Commission or DMV, so it's kind of our governing body that tells us, what's the best way to provide the safest care. We have to have X amount of stroke cases, X amount of providers that need to be on scene, specific type of hospital beds so these patients can be cared for, because this is a very specialized type of patient, and the treatment needs to be specialized as well. So a primary stroke center, they have a neurologist available 24/7, either in person or via telemedicine. So just like on the mobile stroke unit, that FaceTime, that computer is able to see that person there. So somebody doesn't necessarily have to be in-house all of the time. Comprehensive Stroke Center, on the other hand, like I said, it's this 24-hour service for everything stroke that you can think of. Does somebody need to go to surgery? We have neurosurgeons in-house. They meet our patients in the emergency room. Our neurologists meet us in the emergency room as well, so you always have a body here. They're able to take care of the biggest strokes, the ones that are causing some of the most damage and need these higher levels of intervention, be that more diagnostics, bigger CT scans, MRIs, do we need to go to the interventional suite? So all of this is available readily here at Comprehensive Stroke Centers. And the only Comprehensive Stroke Center here in the Aurora area is University Hospital currently. So as I mentioned, our rendezvous process. So it's very exciting and it's pretty cool because we're the only ones in the nation to do a rural rendezvous. Our other mobile stroke units, like down in Houston, where the city is so huge, they do inner-city rendezvous. So they start heading out towards the outer perimeter of the city, and they meet EMS partners kind of in the middle there. But we're the only ones that are actually going and giving this opportunity to our rural patients and communities out there. So we partner with Bennett, Strasburg, and Byers on the I-70 corridor. We get dispatched for them a little bit differently. So here in Aurora, we are with the Aurora Fire Department dispatch. However, out there we work with Metcom. So it's just a little bit different dispatching, a little bit different notification. But we have a very sound process that has been developed to alert us and get us moving out in that right direction. Because we don't want to slow treatment or potential treatment for these patients, we could have a potential 30-minute travel time before we get to these patients and to this destination. So rather than just sitting idly by for that time, we are utilizing our EMS providers out east to do assessments and exams over the radio or over the phone, asking questions from family to make sure that these people are good candidates for us to stop and possibly get some treatment going. So it has worked really well. The rendezvous locations, it can vary depending on where we pick these patients up at. So this is kind of a map kind of highlighting one of our patients that we picked up and just the actual distance that needs to be traveled. So as you can see, the middle of Denver is there on the left side, where that kind of checkered marker is actually University Hospital right here, where we generally are based out of. And clear all the way to the right side of the screen is where this person's address was. So very, very rural. We used MapQuest to just kind of get an idea, and with good traffic and delays, it's about a 41-minute drive for this person to get from his house to the hospital. Now, emergency services, lights and sirens does cut down on that a little bit, but when we looked at this and meeting them in the middle where that star is, we were able to cut down almost 45 to 55 minutes getting this person treatment versus if they would have come to the emergency room. So definitely proving our success and doing what's best for these patients and kind of taking care of them even in that rural setting as well. So all of our EMS partners that we work with receive follow-up on our patients. So we try to provide a phone call to let them know this is what happened, this is what we found when we got them to the emergency room, these are the things that they did. And then we also provide them with an actual paper follow-up sheet that if we have images, we're able to show them, kind of do some case reviews if needed. But we just give information about the patient, and we're able to kind of tell them, this was a good catch, and this is some of the things that we were able to offer this person. So looking at our times, we like to track pretty much everything that we're doing. Again, we're trying to prove that we are efficacious and beneficial to our patients. So we track a lot of our information as far as dispatch to scene arrival. So I don't know how many people know how big Aurora is, but it is actually a pretty big city if you look at it from north to south. There's only one mobile stroke unit here, so we can make it on scene in a median time of 7 minutes. So our drivers, EMTs, paramedics, they are very good at mapping and getting us to the appropriate facility very quickly. Some of the numbers that I want to highlight, so looking at door to CT scan. So when we talk about mobile stroke, it's getting them right into the back doors and starting that CT scan. there are benchmarks and requirements from our governing bodies, Joint Commission and the DNV, for in-hospital care. So in hospital, when an ambulance hits those doors, they recommend that they get a CT scan in the emergency room in less than 25 minutes. Now, hospitals are very good. They have protocols. They are doing, very, very quickly. But the American Stroke Association recommends less than 25 minutes. The mobile stroke unit is getting this person a CT scan in 4. So very, very quickly. We have a designated table. We have a designated team. So everything is open as soon as we get to that person, and we're able to treat them. One of the bigger numbers that I like to look at is the MSTU door to TPA. So when we talk about stroke care, remember TPA is that clot-busting medication. So those governing bodies tell the emergency rooms the same thing. Hey, we think you guys need to strive for getting treatment to these patients in under 45 minutes. And hospitals are very good at doing that. Emergency rooms are very quick. They have processes set in place to make this happen. And here at university, they do have this recommendation of less than 45 minutes, and they're hitting this target a vast majority of the time. When you're looking at our mobile stroke unit, we are blowing this out of the water, and this is nationally. So we are giving TPA in 23 minutes, and we have some PI and QI projects looking to see how can we even decrease that number? How can we get faster? What are ways that we can improve upon this? Because the emergency rooms, they're chasing us. They are getting quicker and quicker with giving treatments and giving this TPA. So we need to be able to, kind of continue to prove our worth and get faster and faster at this as well. So definitely things coming down the pipe with that as far as process improvement, quality improvement for that. So those are kind of our times. So what's next? So I like to throw this out there that, a stroke is not a stroke, is not a stroke, is not a stroke. Every stroke is going to be different. And we need to look at who can accommodate specific kinds of stroke, especially when we're talking primary versus comprehensive centers, and how do we identify these strokes in the field, either with the mobile stroke unit or with traditional EMS. So 2 pictures up here. The one on the left here, as you can see, this is an MRI. On MRIs, anything that is white that lights up like that is going to be that stroke that's happening. So the one on the left is a small stroke. As you can see, it's pretty minimal. However, the one on the right, whole bunch of white going on there, whole bunch of damage that's happening. Are those 2 strokes going to be treated the same at every facility? The answer is no. So how do we properly triage and take these people to the appropriate facility that can best manage their care without having to do redundant transfers and get these and extend the window of treatment for these patients? So the new research is talking about these pre-hospital identification of these large vessel occlusions, or LVOs. So large vessel occlusion, just like it sounds, it's a very, very big artery that is being plugged up that is not allowing blood and oxygen. And the bigger the artery in your brain, the more territory that it affects. So if we go back to these pictures, the one on the right there, it's a large part of the brain, right, that's being affected. So we have a LVO in this instance, a large vessel that is occluded and prohibiting blood and oxygen from getting there. So how do we properly screen for these patients? This was brought up a lot at ISC. It's kind of in all of the new literature and research to give EMS crews the appropriate tools that they need to identify these, to help take them to the appropriate facility. So what makes up an optimal stroke scale? What are some of those optimal characteristics? So anybody that works EMS knows you're on scene. You need to scoop these patients up, assess them quickly, and leave right away and get them to the appropriate facility. So we need something that's simple and rapid, something that's quick, something that's very accurate, something that is reproducible by multiple people. So if Sally Smith does the exam, as soon as they get to the hospital, and Steve, one of the nurses in the hospital, does the same test, they're going to have similar reactions or responses to this test. So we need that inter-rater reliability for that. And then what we need to look at is it validated in a pre-hospital setting? It's easy to do retrospective data and look at patients that come through the ER and kind of retrospectively put together an argument. But to actually go out and train people, teach them how to do it, and then have them do it properly, and then do that kind of data search and compiling is what's needed and what's next. So looking at the stroke scales as well, so when we talked about that sensitivity and accuracy, they're saying that we should avoid missing patients Sorry. Do you have some?
I do. I have a couple questions in the chat room about the mobile stroke unit before you
Yes,
move
sir.
on. So the first question is, are there any plans to integrate this technology with any of the ambulance services up north?
With any other ambulance service?
Up north, like Loveland or Fort Collins,
Oh,
are there
yeah.
any plans
So
to take a stroke unit
that's
there?
the $1 million question. I mean, and the other $1 million question is, are we going to be around even after the data is published and everything? And I think that's all very dependent on what does this data show. If it shows that we are very beneficial and that we are cost effective, that's the other thing. It's very expensive to build one of these. It's very expensive to outfit and to run. So we have to be able to prove that, we are worth it, that our numbers and our treatment times and our outcomes are worth it. We're saving the hospital and the community money by having us. So I think once that research comes out and if it is proving to be beneficial, our hope is that we would see these start popping up, especially in the north region as well. But again, $1 million question, I don't have an exact answer.
Okay, and our next question is, does giving K-Centra require the need for thrombectomy?
Good question. So generally, no. So K-Centra is going to be the medication that stops the bleeding. So this is no longer an ischemic stroke, a blood clot stroke. This is a hemorrhage. So the bleeding is now happening into or around the brain, and giving the K-Centra actually helps stop that bleeding. Now, depending on what the source of the bleeding is, if it's an aneurysm, then yes, they probably will need comprehensive care to go to that interventional radiology suite, or they may need to go to neurosurgery and actually have a surgical procedure to remove some of that damage and blood clot that's in there.
And one last question, what kind of success are you seeing after big bleeds?
For the big bleeds?
After big bleeds? Head bleeds? What kind of success rates are you seeing after big head bleeds?
Oh, big head bleeds. That's the kind of the cool thing is that we are getting lined out with hopefully some research in the future to see for these large head bleeds, if we're able to identify them quickly and get treatment, either the K-Centra or even just blood pressure management. So hypertension, high blood pressure is the #1 cause of both types of strokes, but especially those hemorrhagic strokes. So you figure you have these tiny vessels going in your brain and high blood pressure, you're just pounding at those vessels over the course of 10, 20, 30 years. Once that vessel ruptures, if your blood pressure continues to remain high, what's going to happen? That bleed is just continually happening, right? It's propagating at a very quick rate. So for us to be able to identify them very quickly and then get that blood pressure down to a normal level, we're slowing that bleeding down. Honestly, for our mobile stroke unit, we don't have enough patients or enough data to kind of, answer that question to the fullest extent, but we are able to see that we can bring those interventions quickly. So hopefully when they compile that data and look at our sub-study of hemorrhages, it shows that it is beneficial as well. So one of the things that separates us from traditional EMS as well is having that CAT scan and identifying what is exactly happening. We're able to alert the facility for what we actually need. So if we have a 10-minute transport time to get to the hospital, we're able to call right away and say, we have a very large bleed, we need neurosurgery to meet us at bedside, or start prepping the OR. And what we're seeing is that the times are decreasing from this person getting to the emergency room and getting to intervention as well. So by being able to actually see what is happening in the brain on scene delays a lot of that care once the person comes to the emergency room. So looking at these LVO tools, there is a large number of them out there. I think there's somewhere around 20 large vessel occlusion tools. And again, they all have their pros, they all have their cons. What makes a good LVO tool is we're looking at cortical symptoms. So very, very large strokes are going to cause very routine symptom patterns. So if you're looking at motor deficits alone, these could be caused by lesions, smaller lesions in different parts of the brain that aren't generally affecting a large portion of the brain. But these cortical signs, if we look at vision. So is somebody having loss of peripheral vision, or they're not able to see on one side of their body? We look at aphasia. So are they having difficulty speaking, not making any sense, having word salad? And then we also look at neglect. Does somebody just not even feeling, seeing, or understanding that they have another side of their body because of how much territory of their brain is actually being involved with these large vessel occlusions. Those are those cortical signs, and we only see those in the majority of cases if it's a large vessel occlusion. So when we look at LVO tools, we want to find one that's going to incorporate those signs and symptoms and identify those signs and symptoms, which makes them kind of stand out from some of the other tools that maybe just looks at motor deficits or one or two components of that. So for us here, the mobile stroke unit, and then some of our facilities in the UC Health system, we have decided to endorse the VAN tool. So as I mentioned, it stands for Vision, Aphasia, and Neglect. And as with any tool, it has some pros and some cons. Currently to date, the VAN tool is one of the only two that has been trialed in the EMS setting, in the pre-hospital setting, in the field by actual paramedics on scene. A lot of the other tools have been studied retrospectively or used in the emergency room by physicians or nurses. So you take out, by doing that in the emergency room, you take out a lot of the reality of what an EMS setting in the field actually looks like. Things are happening very quickly. You have very little information to go off of. It's not a very controlled, safe environment. So we want to look at a screening tool that is going to be both effective and specific, but also be very quick. So we don't want EMS providers staying on scene doing an assessment for 5 to 6 minutes and before they actually leave. So we want something that's going to be very quick. So if you look at the VAN tool here, you're either positive or you're negative. The majority of these tools, other tools that are out there, you have to calculate a score, add up. I have 1 point for vision, 2 points for arm drift, things like that. And then at the end, calculate your score and then decide, well, what does that score mean? If I have a score of 2 or less, what does that mean? If I have a score of 5 or greater, what does that mean? So very cumbersome, very difficult to actually perform in the field. So what we are going to trial is this VAN tool where you're either positive or you're negative. And if you're positive, you have a very high suspicion for having one of these large vessel occlusions, so we can decide where we need to take you, be it primary or comprehensive. So this is just kind of a badge card that we're going to have made up to determine how to properly perform the VAN assessment. So the first is that you're going to find out, is there any arm weakness involved? So traditional EMS, I want to say the vast majority use the Cincinnati pre-hospital stroke scale. So it's a very, very quick test, right? What are you looking for? Face asymmetry, arm drift, and speech problems. Well, if you're performing the Cincinnati, you're already knocking off number 1 of this VAN tool. Are they having arm weakness? Yes, continue on per the VAN assessment. So now we're looking at vision. We want to see, are they having any peripheral vision changes? Is their gaze or their vision eyes stuck to one side, which is a very, very likely diagnostic test for having one of these large vessel occlusions. And then aphasia, same thing. In your Cincinnati pre-hospital stroke scale, when you're looking at speech, you're already determining, does this person have speech problems or aphasia that's there as well. And then with neglect, we're looking for some different testing to find out what part of the brain, how much of the brain is affected that could be causing these neglect type symptoms as well. So what's the whole point with all of this? Why would we need to develop this screening? Just like I showed before, each stroke is different and not every stroke is going to be treated the same. So if we identify that a large vessel occlusion is potentially there, these people need to bypass a primary stroke facility and potentially go to higher level of care, which is the comprehensive stroke centers. So what can a comprehensive stroke center do that a primary stroke center can't if you have a large vessel occlusion? So here's another short little animated video of what we call interventional radiology for a thrombectomy, so a clot removal.
Position the balloon guide catheter as close to the thrombus site as possible. Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter, and then connect the continuous flush. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus so that the usable length portion of the solitaire FR will extend past each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and solitaire FR as a unit to the guide catheter tip while applying aspiration to the guide catheter.
So that's a thrombectomy procedure that is performed at comprehensive stroke centers or thrombectomy-capable centers. It's very highly specialized. It happens in what looks like an operating room or a cath lab. So for like STEMIs, they go up through the groin into the heart. They deploy the stents or angioplasty. Same type of procedure, same type of technology, except they're obviously bypassing through the heart, going all the way into the brain, and performing this type of procedure. So you need somebody that's going to be able to do this effectively, and we at Comprehensive Stroke Centers offer this service 24 hours, 7 days a week. So these large vessel occlusions would benefit from coming to these centers right away. So these are side-by-side images of an actual patient who received a thrombectomy. So they're on the left. You can see that yellow arrow pointing. That's pre-thrombectomy. So there is no contrast. There is no dye getting past that vessel and feeding that part of the brain that's in the circle. If you look at the post-thrombectomy picture on the right side of the screen, you see that now that vessel is opened up. You're getting a lot of blood flow. We're now perfusing that part of the brain that was at one point potentially going to be damaged and being starved from those blood, oxygen, and nutrients as well. So it's a very powerful procedure. It's very cool to see these patients who otherwise would potentially be bedbound walk out of the hospital. And that video I showed at the beginning with that gentleman that we treated on board Mobile Stroke, he went to the hospital and was able to receive this procedure, which we believe helped improve his outcomes as well. So what's next for us on Mobile Stroke? Not only are we looking at rolling out a tool to identify these large vessel occlusions with the van, but we're hoping to utilize our technology to prove that this person is having the problem that we suspect. So we are in the process of CT angiography, so a CTA. So we utilize our CAT scanner on board, which would give you just a plain image on the left. Basically tells us whether or not you're having a hemorrhage, but doesn't go any deeper. It doesn't tell me what kind of stroke you're having. Are you having a large vessel occlusion, or what else is going on? But with CT angiography, we would inject dye, just like they do in the emergency room setting, and it would tell us whether or not there is an actual large stroke going on. So that image on the right there where that yellow arrow is, there's asymmetry on both sides between the vessels, so there is a big occlusion, a big plug that's happening right there in that vessel. So hopefully in the near future we roll out this technology on Mobile Stroke and we're able to identify these patients as well. So again, we're going to be utilizing the van tool, hopefully get CTA here in the near future, but what's the purpose? What's the reasoning behind it? So our main goal is to kind of treat these patients, these LVOs, similar to how EMS treats STEMI patients. You identify a STEMI in the field. Generally, most facilities that do a lot of the heart caths and angioplasty and stents have these EMS personnel with the patient, bypass the emergency room, activate the cath lab team, and go straight to cath lab. Well, that's what we're hoping to do, is implement a process and a protocol that would allow our patients to have the cath lab activated, where we can identify these true LVOs in the field and get them straight to that interventional procedure right away. So hopefully that more to come, and that's kind of where our next aim at our study is going to be on mobile stroke for that. Any questions?
So I have a couple more questions from the chat room.
Yes, sir.
One of them, there's a mobile app for stroke scales. I don't know if you're familiar with it. They want to know, do you recommend using it?
Yeah, so actually we are having all of our crews download, because we're endorsing the VAN. There is a VAN assessment app that's out there, and it just helps kind of keep everybody on the right track with assessing anybody that is EMS and gets on scene with these patients. If they're critically ill, there's a lot of things that are happening. There's a lot of people talking. There's a lot of distractions that are out there. So it's easy to potentially get off track when you're performing these assessments. So having an app that's readily available to help kind of guide you through this stroke assessment, we definitely endorse that. And again, we're going to be utilizing the VAN assessment app on our mobile stroke unit as well.
The next question is, University the only comprehensive stroke center in Colorado?
Is University
the only comprehensive stroke center in Colorado?
Good question. It is not the only comprehensive stroke center. We're starting to see more and more pop up. I believe currently we have 4 comprehensive stroke centers in Colorado. University Hospital here in Aurora is the only comprehensive stroke center in the city of Aurora. Then we have Swedish Medical Center, which is there in, I think it's Lakewood or Littleton. And then St. Anthony's Hospital out in Lakewood, out west, is a comprehensive center as well. And then more recently in Littleton, Littleton Hospital has now become comprehensive as well. So those are the 4 that are here in the Denver metro area. And down in Colorado Springs, there is one formal comprehensive stroke center, which is Memorial Central.
And the last question from the chat room, is it appropriate to use the VAN badge card in the emergency department?
I believe so, yes. So down in Memorial Central, they have rolled out using the VAN assessment with all of their ER staff to better triage EMS stroke alerts that come in from the field to identify, do we need to get the cath lab team activated? If they are testing positive for VAN, there's a very high likelihood that this person could benefit from that interventional radiology procedure that I showed. So getting those people activated quicker will help improve the outcomes for these patients. So having those badge cards, utilizing them, is going to be effective. And the other important thing is to just make sure that everybody is on the same page. If you have one ER personnel who is using VAN, it's not the same nomenclature. You know, other people are like, what does that mean? So if something like this is going to be implemented, it's important to kind of roll it out as a whole and make sure everybody's on the same page with the same lingo. Yes, ma'am.
Is the MSTU only activated with Aurora dispatch? So if someone in Littleton calls 911, their dispatch does not activate you?
Good question. Yeah, so we're only dispatched with Aurora Fire Dispatch, and like I said, out east with our partners out there. And you know, that's the rationale behind that is since there's only one of us, and we're trying to do what's best for the patient, is we don't want to delay potential care any longer than we have to. So if mobile stroke was dispatched from here and we were going all the way to a stroke at Red Rocks, you know, it would take us 45 minutes to get there, and EMS could already have this person at the emergency room receiving care. So one of our aims is to ensure, like I said, that our patients are safe, we're providing the best care. So we currently only operate in those city limits in Aurora and down in Colorado Springs, because we've done trials with our times, and that's where we're doing the most benefit and least harm, in a sense, to our patients. But the hope is that if our data proves effective and it's worthwhile, that more hospitals will start endorsing mobile stroke units, and you'll see them at different areas of the city. All right. Thanks, guys.
And just another little piece to add to any education that is needed or wanted. UC Health does offer EMS education, and we will travel to your departments. And these are things that we are 100% involved in and want to be involved in. So please reach out to us. We can come with 15 different slices of actual brains and show clots and bleeds. So if you guys want that education, please reach out to Desmond McNeil, and he can get the right people involved. At this time, guys, we're going to take a 15-minute break. I know if you're here, it says vendor, but we have no vendors due to what's going on right now. So let's just take a 15-minute break, and we'll come right back, all right?
Outlook will make it low.
Yeah.
But
And it should be my Outlook because I'm the one who signed. Yeah, I'm still the one signed in.
it shouldn't take long.
I had to do that in the trailer today.
You know, I think we've basically just proven that we can do this type of education. People will come.
Yeah.
Do you know what I'm saying? Which is a huge tool.
Yeah. Like, I wanted to stand up here while you see this room filled up. I didn't get to do it. I got to wait a year.
We don't do another one. Let's do another one.
Some of these computers are painfully slow.
Yeah.
All right, everyone, we are going to get started again. For everyone who is at home, just remember that you are able to use the chat room on the webinar, so please ask questions. I'm going to present our next guest. This is Dr. Kim Bolton, who resides in Albuquerque, New Mexico, but from D-Town, Denver. Welcome home. She has spent the last 19 years in EMS, the emergency department, and critical care, where she has been an EMT registered nurse, nurse educator, assistant nurse manager, director of nursing, and most recently, the director of patient experience and quality of care department for the emergency medicine and EMS at the University of New Mexico. Her ongoing research includes nurse lead resuscitation and cardiac arrest to allow for ECMO, which is going to be her topic today. And then, in the emergency department, in the increased survivability post-cardiac arrest, increasing patient satisfaction and patient throughput.
Thank you. Good morning, everybody, and thank you so much for having me. Let me see if I can get this going. Again, my name is Kimberly Bolton. I'm here from the University of New Mexico Hospital, where we do ECPR. So today I will go through all my conflicts of interest. I don't receive funding from any of the companies that we work for, or sponsorship or incentives with the equipment we use, or the conferences that helped start us up and build our programs. As well, there's going to be a lot of pictures of patients and real-time scenarios from our facility. We have received permission from the families and the patients to be in this presentation. We just ask that you not save them, copy them, or share them. Okay, so today I'm going to be defining ECPR and explaining our journey to achieving filled cannulation, and that is ECMO the cat. That is kind of our, I guess, person. Well, the cat found us during training and during a simulation, and so we saved the cat. It was feral, and now it's named ECMO, and it comes to a lot of our meetings. So anyway, what is ECMO? ECMO is extracorporeal membrane oxygenation, and it's pretty much where we just do cardiac bypass, where we are allowing the heart and lungs to rest while we can reverse the cause of the cardiac arrest or, a severe anaphylaxis. We do it for that too with VV ECMO. There are two types of ECMO that we do. The veno-arterial, which is VA ECMO. This is where we use a 29 French cannula in the femoral vein and a 21 French cannula in the femoral artery. So my hands are just normal size hands, but the 21 French is the size of my pinky, and the 29 French is the size of my pointer finger. So those are very, very large hoses that we are inserting into people's groins. Get one shot. You don't want to mess up. So this is why we decided on this journey, before we do this, we need to make sure that we are prepared, that we have all of the pros and cons, all of the possibilities, and all of the scary scenarios worked out and worked through. The second one, which is less common, is the VV ECMO, veno-venous, where it does not do the cardiac support. Thank you, sorry. It's venous, so there is no cardiac support. So what is ECPR? ECPR is where we are using ECMO to increase the survivability post-cardiac arrest. For us, we had to define specific roles. We do from 18 to 75 years old. It has to be a witnessed arrest with high-quality bystander CPR. Without the high-quality bystander CPR, they do not even become an ECMO candidate. So this is where EMS became so important to our process, as well as community outreach, which I'll get to later. We will not do ECMO on a patient if they did not have CPR within minutes of the initial cardiac arrest. the team. Before we could develop our policy, procedures, and guidelines for ECPR, we had to identify the team. Within the hospital, it's so dynamic, it's so changing. We realized we have people that are highly skilled that we are not using to their highest skill set, i.e. the paramedics and the nurses. They were not running our CPR scenarios. They were not working to the highest ability of their training and education. Therefore, there was too much that the doctors were doing and the providers were doing, and they could not really focus in on the causes of the cardiac arrest. So we wanted to free up the providers so they could focus in on what was the true cause of cardiac arrest, how can we reverse it, and how can we do that? So we took that responsibility off of them and we gave it to the ACLS captain, which is either an RN, a paramedic, or a resident, usually a second or third year resident, just so they can focus in on the pulse checks, the rhythm checks, epi, bicarb, where are we at, how long have we been down, and just talking with one another, running the defibrillator and the Zoll to make sure that everything was happening and they were decreasing low flow and no flow oxygenation. The resuscitation leader was usually a third year resident or an attending, and as well as the airway doc. So the resuscitation leader is just confirming that everything is going smoothly, that we haven't missed anything, and they work one-on-one with the ACLS captain. The line doc who is actually doing the cannulation is always an attending. We don't have room for error. There cannot be any missed attempts. We need to get these lines in as soon as possible in the best possible way with the least amount of complications. And then obviously RT pharmacy, the ECMO specialists, which are RNs, come down, and then a resus tech, which is either an EMT intermediate or a paramedic within our institution. And in my opinion, the resus tech is one of the most important parts of this role, because they are the ones that are also helping with the Lucas device, which I will also talk about later, and ensuring that we do not have any low flow or no flow times within CPR. So we've all heard 0 to hero. That was not an option with our program. We actually started this journey in 2016. It took a long time to get to where we are now, to where we could have the ECMO in the field, which was a pipe dream. In 2016, we were like, well, what if we could do this like they're doing over in Europe and Australia? We didn't know how to get there because we were so far out from even implementing ECMO within our institution. So from 1995 to 2016, we did have ECMO within the University of New Mexico Hospital. However, it was mainly for the pediatric patients as well as the hantavirus patients. We have a lot of Hanta in New Mexico. There are a lot of rural places. So they would fly in, we would transport them in, and we would put them on ECMO just to improve their survivability. However, all cannulations at that time were managed by the cardiac surgeons as an open cut down. And in 2016, we had a dream to increase survivability post-cardiac arrest, and we knew ECMO was the way to do it. So in January of 2017, the Center for Adult Critical Care took over adult ECMO, and they expanded our indications and the cannulation group, which really opened the door for us to get where we are today. And all of our cannulations within our institution are now performed by 7 critical care and emergency medicine MDs. So in 1995 to 2016, we had less than 1 to 2 adult ECMOs on average annually. In 2017, we were up to 24 adult ECMOs. In 2018, 35. And in 2019, we did 48. So far this year, we have 12 adult ECMOs, and I believe 6 of those were from the ECPR, and 2 were from the field. So again, we do the VA ECMO, VV ECMO, we do it post cardiotomy, and then the pre-hospital. So we started with 2 ED critical care providers, 4 charge nurses, and our nursing director. We all came together with an idea, a plan, and an ask to our administration, as well as the School of Medicine, because we knew this was going to be a big ask and a big undertaking and a huge financial burden to the institution at first to get everybody trained. So we went to the Reanimate Conference. This conference is an exceptional conference. It's 2 days. It's in San Diego. They do it twice a year. And this is really where we understood and learned what is required for ECMO. What do we need? How do we do it? So we went in 2 phases because it is expensive and we couldn't take our entire team all at once. The nurses, the providers, everybody learned how to cannulate. Just so you would understand, we know the nurses are never going to cannulate. We know the paramedics are never going to cannulate. However, they need to know what the providers are going through and what needs to be done around to ensure proper cannulation and safe cannulation, as well as we wanted to go back and eventually get EMS involved. So we spent 2 days, we learned all about ECMO, we learned all about the cannulation process and how to run proper simulations. We ran different scenarios with a very multidisciplinary team. Here you go. They do have kind of jelly-made simulations that they're very high-tech with theirs because their conference has been going on quite a while, and as well as cadavers. So we did get to practice cannulation. We did run scenarios. We did run through the time frame. How long does it actually take to cannulate somebody? What if you run into complications? What if you can't cannulate somebody? Has somebody had a cardiac cath previously? Now they have scar tissue, and how are we going to get through that? How are we going to manipulate the situation to get to the point where we have successful cannulation and we can actually turn on the circuit? Just more pictures of the simulation and practicing. And so when we came back from Reanimate, we all got together and said, okay, this is what they do there. Will it work in our facility? And there were a lot of things that wouldn't. We are a pretty poorly funded facility just because of our population. We are considered a really rural area. Even though we are a big city, we are very rural still from the outskirts. So we had to tweak their process to fit our situation. And so we came up with roll cards, and we defined the roles. And we went out and we talked to everybody in all the different departments. So here in this picture, you will see our line doc down there all suited up. You have pharmacy, you have the 2 nurses, you have I believe he's a paramedic there at the bedside waiting for the patient so he can get the initial IV lines. You have the med electric nurse, and we really just started to prep. And we started to set the scene for this is coming. We need to improve our ACLS. Before we can even implement ECMO, we really needed to get our ACLS down pat because we were noticing there was a lot of chaos in the room. It was very loud. There was confusion, and we were not being as mindful with our time and our pulse checks and our rhythm checks and resuming CPR as we possibly could. So we defined roles, and we practiced those roles, and we identified the best people for each role. And then we really realized through all the simulation and a few practices with actual ACLSs that we had way too much time of low flow and no flow oxygenation with human CPR. So we started reaching out. What are our options? We found the Lucas device, and it allows for defibrillation and rhythm checks through the compressions. So we had to invest in that. We had to figure out how can we afford to bring this machine to our department. With a lot of sponsorship from outside donors, as well as funding from the School of Medicine, we were able to get 1 Lucas device, and we brought it into the scenario, and then we started running sims. Before we put it live, we ran a lot of simulation to ensure that we knew how to properly apply it, that our patients would not have an increased delay because nobody knew how to actually use the machine. So here's and then we built our very first ECMO training model. Dr. Marinero went to the hardware store and he brought PVC pipes, clamps, hoses, and we built this because we can't practice on humans. There are no simulation dummies that will allow you to continually cannulate with garden hoses without completely ruining the mannequin over and over and over. So we needed to be cost effective at this time because, again, we didn't know if we could actually implement this. We didn't know if it was going to be successful and even feasible. So we built our own little ECMO cannulation simulation machine, and we, again, continued to run simulation. So simulation was the most essential part to our ECPR journey. We did monthly simulations, we do annual competencies, and it's not just in the emergency department, it is hospital-wide. Because as you all know, in the hospital, cardiac arrest happens on the med-surg floors. It happens in the ICUs. It happens in the cath lab. So we needed to make sure that if we were going to do this, we were going to do it right. And we were going to make sure that we were going to do it for all the patients within our department. And when we have float nurses to the ER from the ICU, we want them to be able to be aware of what ECMO is and how we're going to do it. So we started it. The best part that we learned, we had a non-medical recorder at all of our simulations, at all of our events, to just record what they observed. They couldn't put in the conjecture of shoulda, woulda, coulda with the medicine. It was all, well, they stopped compressions here, and they started it at this time. Why was there a 3.5-minute gap of no CPR? That really helped us prove we had work to do. We needed to get further along and really improve our practice before we could do ECMO. So, again, we got floor nurses involved, ICU nurses, RT, rapid response, the ED critical care responders, and all the paramedics within our department. We do a biannual ECMO course as well. This is the one coming up here. If anybody's interested, we do have spots open. It is open to whoever's interested in ECMO. And again, we just continue to practice cannulation. We practice the whole simulation from the time EMS is called to the time we get them on circuit. More pictures of simulation here. That is our new little ECMO pump that we finally got, and you'll see why here in a minute. Okay, so here we go. Here's the more into the actual ECPR supplies and time. So again, where I talked about how having that non-medical person was absolutely essential, they identified that we were running times and wasting valuable minutes looking for supplies, looking for the guide wires, looking for the drapes, anything and everything that could possibly happen when you drop a cannulation catheter. What do we do next? So they helped us design an ECPR cart, which is run and checked and restocked by the paramedics within our organization. And then on a simulation, we realized our elevators were too small. So we're doing a simulation in the ER, or the simulation was the patient needed to get to the cath lab. We had an old archaic ECMO machine that altogether was wider than me and just as tall. And you add in a ventilator, you add in the Zoll machine, you add in the stretcher, plus then you have the critical care doc, you have the ER doc, you have the nurse, the paramedic, the ECMO specialist, as well as the vascular team trying to get that patient where they need to be. We didn't fit. And that was a big problem. We were delaying care. We had to find different routes to going into service elevators. So it ended up taking 3 elevator rides and about a half-a-mile walk to get to our cath lab. We took that to our hospital administration and said, we have a good thing going, but we can't get our patient to where they need to be because this machine is too big. The equipment is too outdated and it's too old. Can you help us? And they did. We got a tiny handheld ECMO circuit that we can actually place on top of the patient's stretcher to get them where they need to be. And this was our first save. So this lovely woman came into the emergency department. She arrived through triage talking. She was just very anxious. She had chest pain. She had a recent flight from Haiti to New Mexico. From New Mexico, she drove up here to Colorado. I think she went to Fort Collins to visit some family, drove back from Fort Collins to Albuquerque, all within a 5-day period. She was talking to our ER attending, just explaining why she was on her trip, how she was feeling, and she went into witness cardiac arrest. We obviously immediately started CPR. We were suspecting that obviously she had probably a massive PE from her travels, and we moved her back to our resuscitation bay where we called our first ECMO case. We paged out our first eCPR case. And a lot of people were expecting it to be just another simulation because we ran our simulations as if it was a real patient. We paged it out over our system as eCPR now, and everybody came. We got her cannulated under 30 minutes, and she went home with no complications, I think 6 days later. What we learned from her was very valuable. We did use the Lucas device with her. However, on the mannequins, you don't realize the damage the Lucas device can do if it migrates and if it slips down. And with her, due to her anatomy and breast tissue, the Lucas device did slip down, and she did end up with a large liver laceration from it. So what we took away from that is now one of the techs that's in charge of the Lucas device, that is, once it's applied, that is their number one thing. We mark it with a Sharpie. We mark the line where it cannot go below, and if it starts to travel, that provider calls it real quick. We stop the Lucas, and we replace it. Since this unfortunate learning experience, we have not had any more liver lax or issues from the Lucas device. Another VV ECMO survivor, this gentleman was a severe anaphylactic case, came in, was brought in by EMS for anaphylaxis, and went into cardiac arrest within the department, and we were able to get him on VV ECMO. Up until this point, we have really not publicized to EMS that we were doing this in hospital. The rumor was out there. However, we did not have any conversations with them because we did not want it to become this great big huge rumor mill and exaggeration. This is what we're doing, until we had all of our ducks in a row. We wanted to implement this one time the right way. So this is where, people started asking, hey, what are you doing? We heard that you did this for a cardiac arrest patient. Is that true? And so we started having the conversations little by little. Yep, we did do that. Do you want to stay and watch? The EMS crews from Rio Rancho Fire as well as Albuquerque Fire Rescue started to hang around a little bit more to see what we were doing and how we were doing it. Another in-house cardiac arrest. This gentleman was there for, I don't remember why he was admitted, but just increased cardiac problems, and he went into a cardiac arrest. This is his chest view, where he had a pulmonary artery aneurysm. You can see the little white wires that are free floating up there. Those are the coils from his thoracotomy. We were able to place him on ECMO under 40 minutes, I believe, was the time for him, and he went home. Any other time we've had patients with similar, they did not have the great outcome that he did have. The next case that I'm going to show you is what really brought us to the field. And this case opened us up to having an amazing conversation with Albuquerque Fire to grow and to build an even stronger relationship. On Christmas Eve, this wonderful female was shopping, and she went into cardiac arrest. Her family member that's at bedside there started CPR. Albuquerque Fire Rescue showed up. They were able to transport her to our facility, and we began the eCPR process. This crew had never seen eCPR. They had not really heard much about it, and they hung around, and they watched the entire process, all 3 phases. They were so excited to see what we did, and they wanted to help. They wanted us to grow with, or they wanted to grow with us and help improve this process. another ECPR survivor that Albuquerque Fire Rescue brought to us. Cardiac arrest at home. They were able to get ROSC. They brought her to the emergency department where she again went into PEA arrest. We cannulated her just under, I think, 45 minutes, maybe closer to 50 minutes, got her up to the cath lab on ECMO, and they were able to stent her and open up her vessels, and I believe she went home within about 10 days of her cardiac arrest. Absolutely no complications, no increased neurodeficits, back to her normal quality of life. So now we felt, after several ECPR, that we were ready for the field. We had to identify all of our community partners. We had to write a whole lot of protocols. We had to work very closely with Albuquerque Fire Rescue as well as Albuquerque Ambulance. They are the service that helps kind of overflow with our overflow patient population and transport, because Albuquerque Fire just cannot keep up with all the calls and transports. And that was really hard because Albuquerque Ambulance is owned by one of the competing hospitals, and to get them to work well and to support this initiative took a lot of time. We had to convince them that we're not trying to take your patients. We're not trying to divert patients that you can care from. We just want to do what's right and what's best for these patients. So we started running simulations in the field. We started just pretending like there was a patient down, and can we get this patient back to the hospital in time? Is it safe for the crew? Because our number one responsibility is to keep these crews safe. We want our EMS partners safe at all times. We do not want them transporting a patient that has no likelihood of survivability and putting themselves at risk, or the other citizens within Albuquerque. As you all know, transporting throughout the community and through busy populated streets can be very dangerous. So we continued to run simulations. We created schedules, and we waited. We waited for the perfect opportunity. We waited for the time when we could do this safely, effectively, and efficiently. And so while we were waiting, we continued to run different scenarios. We started advertising that we do ECPR to other outlying facilities, our hospitals and our critical access facilities, to let them know that this is something we are offering and we are willing to come do. We are willing to come cannulate patients at your facility to get them back to the higher level of care that they need. And so while we were waiting and we were still working with EMS and fire, we continued to grow and build our skills and our ability to do ECMO and to cannulate these patients in the most effective, efficient way, as well as getting more of our ER and critical care providers cannulation certified. Because it's, like I said earlier, it is a one shot to get these large cannulations done. There's no time to waste. And here we are in our lifeguard, just again practicing, finding out, hey, when we did this in the hospital, we realized that none of this would fit in our elevators. Can we actually fly this rotor? Can we get machines that will work in our Cessnas? And we did, but we did have to, again, rethink logistics. How many people can we bring? We have one of our critical care docs who's 6'7". Will he fit? Can he actually be a field cannulator? Because is he going to be able to fit in the rotor with the equipment and the patient and the team? And then we packaged. We went to a facility and we did a hospital cannulation, and we packaged up the patient, and we learned from that too. And we learned that we need an extra set of hands. So in these areas, EMS is vital for us because these little critical access hospitals, they don't have extra staff that they can help us. So we built relationships with outliers, tribal medicine, the rural volunteer EMS services, so they can help us when we need them. Again, more practice. transporting. What is better? Should we send the rotor or should we always do fixed wing? 2 more ECMO survivors. Both of these were the older gentleman was cannulated at an off-site hospital and flown in. He's doing amazing. We still hear from him and his family about how thankful they are. The younger gentleman sitting down was an ECPR case, again transported by Albuquerque Fire and Rescue to the facility. He went into cardiac arrest in our resuscitation bay, and we were able to cannulate him within under 30 minutes, and he went home no deficits as well. This gentleman is our longest ECMO run to date. He was on ECMO for 61 days, and that is him up sitting doing PT-OT while on ECMO. This is an amazing feat and an amazing process that we learned while building this program, was that these patients can be awake on ECMO. And the more they lay and the more they sit and the more they atrophy, the harder their recovery is. So the sooner we can get them up and moving, the better. And so we are. As soon as they're stabilized and they are strong enough, we get them up moving. We get them up working with PT and OT. But as you can see in the picture with him sitting, we have very close watch of those cannulas, because if they come unhooked, it's a matter of seconds before these patients can bleed out. And here's a second patient up walking on VA ECMO. Remarkable case again. He was one of our ECPR cases. He had a large PE, and we were able to get him cannulated and to interventional radiology to help treat his reasoning for his cardiac arrest. Here's another one of our ECPR patients that I am almost certain would not have made it if we did not offer ECMO within our emergency department. This patient ended up getting plasma apheresis, CRRT, and being in the ICU for several weeks, but they too went straight home from the hospital. They did not have to go to rehab. They did not have to go to a skilled nursing facility. Again, another one of our ECPR patients came into the hospital post-cardiac arrest, went in again to, after regaining ROSC, went into cardiac arrest again. We were able to cannulate them. We do not do LVADs at our facility, so we were able to transfer them down to Baylor, and they were also discharged home. And then we got the call. Dr. Darren Brody, who is part of our EMS consortium, was working that day, and we got a call for a 50-year-old woman, respiratory distress, unsure etiology. Albuquerque Fire Rescue did call Dr. Brody because he was the medical specialist out in the field that day, and so he responded to the scene as well because the EMS crew and fire crew were really worried about her. At the time of their arrival, she was up speaking, she was talking, however, she had clear cyanosis, she was tripoding, very 1 to 2 word dyspnea, and she went into cardiac arrest right in front of the fire crew. They called Dr. Brody, initiated CPR and ACLS, and they called Dr. Brody and said, this patient meets all the criteria for our ECPR, please respond. He was on scene. He happened to be, all the stars aligned this day. He happened to be 7 minutes away, arrived to her house, went through our protocols, went through our exclusion-inclusion criteria, and said, I agree, this patient is a candidate, let's cannulate. So he set up, and everybody, we get calls all the time. What was your first rig? How did you do it? This was it. This was our first field ECPR response vehicle. We didn't have anything else. We didn't know what we needed. There is little to no research of what you should and should not have equipment-wise. So the family was wonderful. They said, yes, let's do this. and they cannulated this patient in their house. With the help of the supplies from this, and then obviously the fire truck and the ambulance that was there had room as well. So after that, Albuquerque Fire said, we need to help you. You cannot do this out of a Suburban. You cannot do this out of an old Explorer. What can we do? So we sat down again, developed a plan, and said, we need an ambulance. We need an ambulance that we can strip down because it can't be running other calls. It can be an older ambulance, something that you guys are about to retire, and they did. They had one. They had an older rig that they were going to retire because they needed bigger access. And so we went in a partnership and purchased their old ambulance and turned it into ECMO 1. It does only run Monday through Friday right now, 8 to 5, due to staffing issues, provider issues, lack of cannulators, and just lack of resources. And then we realized the ambulance is great, it's still just not quite big enough. And it doesn't allow for enough protection from neighbors, bystanders, the community. We need a little bit more room and shelter to not only protect our employees and the fire and rescue, but also the patient and their family members and their privacy. So this was our second field ECPR case, and it was a witness arrest by a bystander. CPR was started, and they were down less than 20 minutes, as our protocol states, and we got them on ECMO under the 60 minutes. The tent was game-changing. It's a very cheap option, but it does provide the quick put up and take down so we can focus really on cannulating the patient, providing space, and ensuring everything needs to get done does in a timely manner. Here is the ambulance again showing up in the ambulance bay, trying to offload that ECPR patient and trying to figure out the logistics of who needs to be at the back door to let them in. Where are we going? Are we going straight to the ER with this? Or are we going up to the cath lab? Are we going straight to the ICU or to the OR? Where does vascular want them? Here's a better look at the back of ECMO 1. As you can see, it's a normal Stryker EMS stretcher, but we have taken out everything other than the ECMO machine, a hand crank machine, the supplies, the cannulation supplies, and then as well as anything that each provider kind of has their own little set of supplies that they want, and so we make sure we have those all on there. Here is the pre-cannulation setup, and the hand crank is right there at the head of the bed. Let's see, let's see if I can show you here. It's kind of a hard picture to see, but it's just a little circle that's right there in the middle of the top by the blue. And it literally is a hand crank that has to be continuously turned and rotated manually without stop and without fail. So here is our amazing paramedic who is trained on the ECMO machine. This was from our second field cannulation. Here you can see how they are completely gowned up, gloved up, and actually cannulating our patient here. It is very messy. It is very delicate and intricate, so it was very important that the ambulance does not have any extra equipment that isn't needed. The hand crank ECMO machine is $5,000 versus that little handheld one that goes on the bed, which is $120,000. Again, we didn't have the money to purchase another actual machine, not knowing if this was going to be a program that was doable, feasible, and survivable. If it doesn't work and we can't justify it long term, we can't justify spending $120,000 on a machine when we could get the hand crank one for $5,000, train highly skilled, highly educated, capable Albuquerque Fire Rescue teammates to help us in this process. And they were more than willing to. They were excited to help and learn and be a part of this. And we couldn't do it without them. The nice thing, too, about this is once we get these patients on ECMO, it's still an emergency, but it's not an emergent situation. We have time to ensure safety and stability. We have time to secure those lines. We have time to get a better airway in the patient. And we have time to safely transport these patients through the city across the streets following regular traffic laws. We didn't ever want to put anybody else at risk in our city, especially our providers, doing something that wasn't always necessary in the field. So we take time on scene. We make sure that the patient is stable, that the staff is ready to move, that we have the circuit going, that the paramedic cranking the ECMO machine is not getting too fatigued, and that can continue for maybe a 15-20 minute transfer depending on traffic, maybe a little bit longer if it is rush hour. And so we do always have somebody back up to take over the hand crank, because it is not an easy crank. You are circulating the blood through the entire person's circulation. We then cover everything and ensure that the circuit is ready, that all the supplies are done, all biohazard is taken away. You can see at the bottom right-hand corner, that is Dr. Detmer's knee from cannulation. He is quite soaked. So we did learn another valuable lesson from here. We need a little bit better PPE for our providers and our cannulators, because you didn't know. We didn't know in that tight space. We'd never cannulated in the back of an ambulance before what was needed. What do we need for our EMS teammates to keep them safe? What do we need to help shield the families from seeing a rather invasive procedure, but also ensuring that they know that we're doing everything for their family member? So where we're at today, we've had 2 field cases to date. We have been dispatched to several others, but when we get on scene, they're not candidates. Either they have end-stage renal disease, unknown downtime, cancer. We will not cannulate a cancer patient. Once a patient's on ECMO, they're on ECMO. You can't just turn it off without a lot of conversation and a lot of in-depth thought. So we're very conscientious about who we put on ECMO, because it is very expensive. It is very hard to take a patient off ECMO that should never have been put on ECMO in the first place. We do not have any survivors yet, but we know that day will come. The positives were, after talking with the family members, the 2 amazing families of the patients that we worked with, they really said, we know our family didn't survive, and that is terrible, but we all got to say goodbye. We all got to hold our family member's hand. Family got to fly in. They got to drive in. They got to say their last I'm sorry's. They got to say their last stories. They got to hold a warm hand and talk to their family members and say goodbye. These patients survived to donation, which is a huge win. So they gave the gift of life to several other people. And to me, it is unfortunate that we have not had an ECPR success, a field ECPR success yet, but we did save a lot of other lives by bringing these 2 families and these 2 patients into our facility. And then the biggest one, though, is that the family members are at peace. They know that everything possible was done. Our major negatives are that we don't get any reimbursement for this. We cannot bill for it at all. Albuquerque Fire Rescue cannot bill for it at all. There's very limited hours and limited locations. We had to map out the city. Where are the patients going to be that this is doable? What areas can we work with? what governmental limitations, because we are surrounded by Navajo Nation and a lot of reservation land. Will they allow us to do this in their land and on their areas? So there were a lot of strategic planning and construction. Every day we have to take in construction into mind. Can we do it? Because now this major highway is down to 1 lane where it was 3. Can we get there? Can we get them back? So there's a lot that's still ongoing. And I think we will continue to grow. I think we will continue to learn and improve. The one big outcome is, though, that we are improving our ACLS. We are improving our low-flow, no-flow CPR time. We have improved our teamwork and our communication. CPR events now and resuscitation events now are calm. They're a lot quieter. There's no yelling. You can use an inside voice and talk and say, when was the last epi? Is it time for a pulse check? At that tone, we don't have to yell. There's no chaos. Everybody knows the system. We have a very good working routine through that, and everybody knows their roles, including EMS. They know that if they have a person that is not good for field cannulation, but will probably be a great in-house cannulation, they give us a heads up, and they stay, and they say, can we help? What can we do? And our resuscitation leader has a vital role with the EMS, getting the full story. Can you talk to family? What did family tell you? Who was doing CPR? Was it a 5-year-old grandchild, or was it an adult that actually got good compressions? So those relationships and getting a really, really good story from the field is vital for both field cannulation as well as in-house cannulation. Let's see here. And a big, huge thank you to these 3 providers. This would not have happened without their diligence, their dream, their pushing the limits, their thinking outside of the box, and their sacrifice. They give up a lot of their personal time to map out the roads of Albuquerque, to reach out to Albuquerque Fire Rescue, to improve the equipment we have and the relationships we have with EMS. And it is vital. We couldn't be here without them, and we would not be here doing any of ECMO without them. So I just wanted to make sure to give them a nice thank you, because they have been wonderful. Any questions? Yes.
All right. We actually have a few from people online here. First question. Can an EMT attend the EP ECMO course?
I don't know that. We let our EMTs at the hospital, so I don't see why not. Yeah, I've never been asked that, but yeah, our EMTs and our paramedics from within our facility do, so I would say absolutely reach out to Isaac Towell. Mm-hmm.
Does Albuquerque Fire Department have the auto pulse on their ambulances?
I'm sorry, what?
Does Albuquerque Fire Department have the auto pulse on their ambulances?
No.
No? Okay.
Not yet.
This is actually based on one of your pictures of the patient who you guys had up on the ECMO.
Yeah.
Someone is asking, when you walked your VA patient, what was his cannulation? Was it?
What? Sorry, I didn't hear the last.
They're asking what was his cannulation? Was it venous?
Oh, it was femoral artery and femoral vein. Yeah. So we had that one was the scary one. I was back in the back, and they said they're going to walk him, and I was like, wait, what? You're really going to walk them? I think I'm going to throw up, because we have never had a patient, luckily, thank goodness, decannulate within our facility. But I saw a video at that Reanimate of a patient that did get decannulated, and if a patient gets decannulated, they cannot survive. The blood shoots everywhere because they are on a pump, and I think it was about 7 seconds, and just about the entire blood flow patient's blood volume was in the room. So this patient had a VA ECMO, so 2 large hoses in their groin, and we had 1 nurse on each hose making sure that it was not pulled out, disconnected, or anything, as well as the ECMO specialist watching the machine to make sure there were no bubbles, clots, or anything. And they did fine. They're very secure in there, but it's very scary at first when you're getting up somebody that has a lot of equipment that anything goes wrong could end all of our amazing efforts very quickly. So yes, it was intense. It was pretty impressive.
Is there a system in place to fly the team to more remote locations via helicopter?
Yes, we do. We have a very amazing team and in a very amazing setup now where we do have the small handheld, not the crank ECMO, where we fly out and cannulate and then bring back. We do have the automated actual, it's the size of a Zoll machine, and we have teams. So right now our call is we have 2 cannulators. We have the one that works with lifeguard and then the one that's for the field Albuquerque Fire Rescue, as well as in-house we have different critical care docs on, and they're willing to hop in the rotor or the fixed wing and go cannulate at any time.
How far out is your service area from your facility? 15 to 20 miles?
Right now, we're doing more on a time basis because it's not really that easy. We can't say 30 miles because of traffic and everything, so we try to say within 30 minutes, a 30-minute drive, and we have it mapped out. But it really comes out to be about 20 miles circular. Mm-hmm.
Are there any questions inside the room? All right. Thank you so much.
All right. Thank you guys so much for having me.
This is it?
Jump right. Yes. Thank you.
You're welcome.
I appreciate it.
See who we have. Yeah, Robbie. So he's going to just do the numbers. All right, and then our next presentation is going to be from the Director of Trauma Services. This is Robbie, and he will talk more about some upcoming construction and with Tower 3 and how that impacts EMS here, okay? Thank you.
Thank you so much. This is actually a pretty exciting thing for all of us here at university, and it does impact what's going to happen with EMS. So we thought we'd spend a few minutes today talking about it and showing you some rendering drawings and maybe a plan for what the new tower is. So I think one thing that, if any of you transport patients to the University of Colorado Hospital that you do know is that we are very, very busy. And we often operate at nearly our capacity and, have times where we have to hold patients in the emergency department in order to make inpatient beds available. And so that is challenging. It's challenging for our staff, challenging for you all. So the Board of Directors of the University of Colorado Hospital and the UC Health System approved construction of a 3rd patient tower that's actually going to begin in summer of 2020 with a estimated completion date of fall 2022. The tower activation is going to go on through the summer of 2023. So this isn't just a 1-year, 2-year project. This is something that's going to affect us for many years to come. As a part of this, we're actually going to be relocating the EMS entrance while we construct the tower. So where you pull into now in the Circle Drive, that's going to completely change. And the ambulance bay is now going to be in the existing loading dock of the hospital. So we actually moved the loading dock, built a new loading dock to accommodate for our EMS colleagues to be able to bring patients and transport them safely. It's a covered area, and it is exactly where the loading dock is now. So we're going to do everything we possibly can to minimize disruptions and ensure safe care during that whole process. The picture that you're seeing on the slide is an actual rendering of what the tower will look like. So you can actually see where that Tower 3 is. That'll be what the new tower looks like. You can see it's pretty reminiscent and similar to the current AIP 2 tower that is standing there. And then you can see to the left where the employee parking garage is. So you can see it'll occupy a good chunk of that space where the current EMS entrance is now for the emergency department. So we're very, very excited about this, excited to have more capacity. This is right now as it stands, and I will tell you this is a very fluid process. This is what the tower looks like right now in terms of what the floors will look like. We'll actually have a couple of floors that are shelled out for future use that actually won't be used initially during the initial development. We're going to be activating an inpatient behavioral health unit with Tower 3 and opening one of the shelled floors that we have established. So that is something new that's an update. So we will have inpatient behavioral health services at University of Colorado Hospital, which is something that we don't have currently. And really we're looking at our ability to expand our high-end acute services like trauma, CT surgery, neuro, pulmonary, all of those things. And part of the reason why we're adding 8 operating rooms is to be able to accommodate some of those services. We're also, as it relates to trauma, relocating our blood bank to make the blood bank in closer proximity. As far as the emergency department, we're going to have 20 clinical decision unit beds now. Currently we have 16, so 4 of those will be new. 50 treatment rooms, which is not really a change, 7 super track rooms. And I talked about the new temporary loading dock and how that will affect the EMS ambulance bay. So while the ED is going to be impacted, we have phased the plan so that we don't lose capacity in the ER to ensure that we can continue to have smooth operations. I'm pretty excited because along with this, our resuscitation bays are also going to be updated in the emergency department. So pretty excited to have, some new rooms. It's always nice to get something new. So we're really super, super excited about this project, and we thought we would just take a few minutes today to update you on where we're at, realizing that this process can and probably will change as we move forward, but just continued growth here at the hospital that we're all super excited about. So I'll take any questions. Any questions on the webinar?
Yes. First question is, with this new tower, will we add another helipad to this tower?
Will we be adding another helipad?
Helipad.
So the building is currently structured with the ability to do so. However, it's not currently in the plan. As I said, though, the plan does change, I would say, even day to day at this point. So structurally, the building is capable of having a helipad added to the top of it as it stands now.
Will they add more parking garages for patients?
That's the question. You know what? I'm glad I'm not in charge of parking here, so I can maybe provide some, assistance. But I do believe there is a separate plan that has nothing to do with Tower 3 that is going to address parking on the campus. I don't know the specifics of that plan, but I do know that it is 100% on the top priority list. Obviously right now second to coronavirus, but it is a high priority for the organization, and people are very, very mindful of parking as it relates to the new tower.
Correct. And I can answer a little bit about parking. Being in my current role, I get these complaints all day. There will be a new parking tower going up for patients and visitors here. I believe they said they break ground toward the end of summer. So that will be coming, 250 more parking spaces. So that's helpful. It's not enough with a third tower coming up, so they'll probably work on that again. Another question, will the construction affect the patient care abilities? I'm not sure.
I'll tell you that we are doing everything we possibly can to try to ensure smooth operations in the emergency department. We've specifically phased out things the way that they've been phased out so as to not impact patient care. Same thing with the ambulance bay relocation. I know some of you, we had to close the EMS lounge for a few days here and there. We do also have plans to relocate the EMS lounge as necessary, so we won't go without an EMS lounge for an extended period of time, as we have plans to relocate that as well. So as it pertains to patient care, we're doing everything possible to make sure that it doesn't impact the flow of patient care or our operations. And part of that is just phasing things out to make sure that it doesn't do that.
Someone asked, with the ambulance bay moving to the loading dock area, once the tower is done, will that go back to being the ambulance bay underneath Tower 3, or will there be a brand new ambulance bay altogether?
No, it sounds like the ambulance bay will go back to its original location, but not until the end of the phases, which would be in 2023. So that may be one of the last phases that actually takes place, is that, we'll relocate the ambulance bay. So it will be in the loading dock for a couple years. If you haven't been in that space, it's actually a pretty nice space. It's covered from the wind and all that good stuff, and I think people may end up liking it more than they actually like the current ambulance bay now.
Have we considered a roof-level resuscitation surgical suite at the Henry roof level for incoming traumas?
We have not, but I will tell you that internally within the trauma program, we talk about direct to OR transfers a lot. We have done some direct to OR transfers to this point. Typically when we know the diagnosis of the patient and we know that that patient is needing operative intervention, there are no plans for a rooftop resuscitation area. However, it's a great idea. I just, I don't know that that is in the plans currently.
Someone is asking, will floor 9 and 10, will they be medical, surgical, or cardiac ICUs?
I think that's actually still being sorted out. Right now, they're just being constructed as intensive care units. I know there's been a lot of discussion on the nursing front about the relocation and who will be in what unit. So I'm hesitant to say exactly what's going to go where, because that's very fluid and could change day by day.
EMS lounge in Desmond's office, party in Desmond's office.
Yes.
Or 12th floor penthouse.
Yeah. So yes, if we don't have the EMS lounge, we'll just put all the food in Desmond's office, and he'll have to figure out what to do. But no, we're super happy that the hospital's committed to actually relocating that during all this construction and making it available to everyone.
How many rigs can fit in the new ambulance bay area? Will our EMS triage system change?
Did you say the EMS systems? Yeah, so I would say Desmond might be in a better position to answer this, but my calculations are that we could fit anywhere from 5 to 6 ambulances in there comfortably. But Desmond, do you have a better answer for that?
Yeah, I would imagine we can probably fit. It's larger than the current ambulance bay. I feel like we'll probably be able to fit 10 to 15 normal sized ambulances into that bay at a time. And plus, there's always the transfer out, but the loading dock is much bigger than the current EMS bay. As far as the triage system, that will stay the same. We'll still be able to take. We're still a level 1 trauma center. We'll be able to take everything we normally take now. We're still a comprehensive stroke center. We'll still be able to take that. Everything you call in on the radio will still be the same.
Yeah, and realistically, the distance from the current ambulance bay to the resuscitation rooms is very similar coming in through the back door as it is coming in through the entrance that you come in now.
Yes, there's going to be a change in the pathway of travel, which we'll share with our EMS providers. So there'll be a slight change in the next. In June, the dock should open up, and there will be a change of pathways into the ED and how you get to the trauma rooms, but we'll be able to sort that out relatively quickly.
All right, any other questions? Thank you guys so much, and I do have to say that Tom Gronow was planning on coming to do this presentation. However, he as well is wrapped up in COVID-19 planning and everything, so hopefully I didn't misrepresent him, but he apologizes for not being here and is certainly wish that he could have been. So thank you guys so much.
All right, our next presenter is Dr. Angie Wright. Dr. Angie Wright is one of our ER physicians who is also a Denver Health emergency medicine resident here with University in Denver Health. So she's been here her entire healthcare career, stuck with me. Angie is now one of our EMS directors and also helped put this program together. And with her and the help of several others, we're trying to build our EMS program. So Angie is going to present today on the virus that has emptied this room out prior to it being filled. So have a good day.
Thank you. All right, thank you guys. As Daryl mentioned, my name is Angela Wright. I'm the Assistant EMS Medical Director for the University of Colorado Hospital, and I'm honored to be here speaking with you guys, both in person and virtually. I'm going to do a brief talk on what likely warrants many more hours of conversation, and it's the reason that we're doing this conference virtually as well, and that's COVID-19. I will say it's challenging to prepare a talk in a topic that is changing every single day as the situation evolves, but as of this morning, the data that I have in this talk is the most up-to-date and accurate data that we do have access to from reliable sources. Please feel free to ask questions throughout the presentation via the chat. More than happy to answer them as we go along or at the end. So there's a lot of information out there between the CDC, the WHO, local news, national news, of course, social media. I think it's absolutely essential that as scientists and as healthcare professionals that we take a very pragmatic, data-driven, level-minded approach to this entire topic. There's a lot of emotions wrapped up in this topic. There's a lot out there, but I think it's our responsibility to understand fact versus fiction. So I'm going to try to spend the next 20 to 30 minutes demystifying some of the information out there, confusing us all a little bit more with the things that we don't know. So an outline for today, we're going to talk about what we know, which is very little. We're going to talk about what we do not know. We're going to talk about why we do not know these things. And we're going to talk about what we can do, or actions moving forward. So what do we know? We all know that COVID-19 is the name of the disease, so the coronavirus disease caused by a novel coronavirus that was first discovered in Wuhan of the Hubei province of China in December of 2019. The virus itself is known as SARS-CoV-2, or Severe Acute Respiratory Syndrome Coronavirus 2, and the 2019 nCoV is the abbreviation for the 2019 novel coronavirus. So all three of these things are just a different nomenclature for what we're seeing right now, and COVID is the name of the actual illness when the virus infects a human. The virus was named by a International Committee onto the Taxonomy of Viruses that classified this virus based on its structure, molecular structure, as a family member of the Coronaviridae, which is a sister virus of the SARS-CoV that caused the outbreak in 2003, and also the MERS-CoV, or coronavirus, the Middle Eastern Respiratory Syndrome, which has resulted in a number of deaths since 2013. The SARS-CoV-2 is a beta coronavirus. It likely originated in bats. I tried to find a cute picture of a bat so that we didn't all walk away from this hating bats. So this is the cutest bat that I could find. All three of the viruses that we talked about, SARS-CoV-1, SARS-CoV-2, and MERS, are part of this family of coronaviruses, and the thought is that they all initially were discovered in animals, and then they were transmitted subsequently to humans. But how does it spread? It initially, like I said, probably came from bats, but at this point, what we care a lot more about is the human-to-human contact and the human-to-human spread of the virus. So we're going to talk a little bit about that. There's a lot of misinformation out there. But this virus, as far as we know, is spread via droplets. So this is a picture of someone coughing and sneezing at the same time. These are the droplets that come out of their nose and mouth, and this is a droplet spread virus. If the droplets or the liquid particles land on a surface and you touch the surface and then touch your face, you can contract the virus. If you're standing close to somebody when this happens, then those can go directly into your eyes, into your mouth, into your nose, contact your mucous membranes, and you can contract the virus. People can spread the virus if they're not exhibiting any symptoms. However, as you can imagine, if someone's actively coughing and sneezing, it's going to be a lot more contagious because they're actively expelling these droplets into the air. Now, in the healthcare field right now, there's still recommendations, although institution by institution, these recommendations are changing, that we wear N95 masks. I'll talk a little bit more about that in a little bit. N95 or PAPRs are a way to protect you against airborne viruses and illness, such as tuberculosis. Airborne is just a virus or illness that doesn't need the droplet or that particle that you see here to carry it through the air, so it just exists in the air. As you can imagine, those can be a little more concerning and a little more contagious, and out of an abundance of caution, until we know more about this, we are recommending the airborne precautions. Now, there are already institutions in the Denver metro area that are changing this because we do know it's droplet spread. We don't think it is airborne virus, and so they're changing the recommendations to drop the N95s, but that has to be done on an institution basis with the guidance of public health. The other important component of something that's spread via droplets, as you see here, is that, as I mentioned, it does land on surfaces. How long a virus lives on a surface depends on the temperature of the room and the humidity of the room. Right now, we think that the SARS-CoV-2 can live on a surface for anywhere from 30 minutes to 9 hours. So really a big window there, potentially up to 24 hours if the conditions of the room are absolutely perfect, which is why people are talking about washing your hands frequently, because if you're touching these surfaces and you get into contact with something like this and then you touch your face, you can contract the virus, cleaning high-touch surfaces, etc. So we will talk a little bit more about that when we talk about what we can do. But that's why contact precautions are important as healthcare providers, because if you're wearing gloves and a gown, you're protecting yourself from the droplets that are either in the air or have landed on a surface and can infect you. So the coronavirus, the family of coronaviruses, your typical symptoms are going to be fever, malaise, dry cough, myalgias. Your less common symptoms are rhinorrhea or nasal congestion, sore throat, and diarrhea. And your rare symptoms, difficulty breathing, severe pneumonias, renal failure, septic shock, and ARDS. It's important to look at these because what we're seeing with this SARS-CoV-2, and also that we saw with both SARS-CoV-1 and MERS, is that they're really infections of the lower respiratory tract. So while some people that contract the virus will have your typical kind of sore throat, runny nose, upper respiratory symptoms, for the most part what we're seeing is lower respiratory infections with this, into the lower bronchial trees and even to the alveoli, causing pneumonias, which is what's causing the severe respiratory symptoms going forward. So the less common severe cough, things like that, have made their way into how we screen and test people, which we'll go over. But sore throat and runny nose don't qualify you as someone that potentially may have COVID. This is a scanning electron microscope of an image of a COVID-19 from the SARS-CoV-2 virus, from the National Institute of Allergy and Infectious Disease, which is here in Colorado. It's kind of a pretty picture, but it's a terrible thing. There's a few other terms and concepts we need to fully understand and that we can put into the what we know category. The basic reproduction number is known as the R0, and the R0 is a calculation of the expected number of secondary cases produced by a single infected individual. And it describes a situation where there is no prior exposure or immunization. So in a situation like we're seeing with a novel coronavirus, because this is the first time that we've identified this particular virus as causing human infection, we need to calculate the R0. The R0 for some illnesses that we do know are measles has an R0 of 12 to 18 people. So this means if there was no prior exposure or immunization, so prior to widespread vaccines, if one person got infected with measles, we would expect 12 to 18 additional people to get infected with measles from that one person. So smallpox, you can see, has an R0 of 5 to 7. SARS is 2 to 5. Ebola is 2. We think that SARS-CoV-2, based on the calculations and modeling, has an R0 of approximately 2.2. So this means that for every single person that gets infected with SARS-CoV-2, we expect that person to infect 2.2 additional people. Any virus with an R0 greater than 1 indicates a virus that has the potential to cause an outbreak. Because as you can imagine, this is going to increase exponentially, which is why you see these outbreaks, because each person then goes on to infect 2.2 additional people, and that gets a lot bigger very quickly. The 1918 pandemic strain of influenza had an R0 similar to what we're seeing with SARS-CoV-2, and MERS actually had a very small R0 of 0.3 to 0.8, which is, while it was very deadly, which we'll talk about in a little bit, it was not quite as widespread. So what do we not know? And the answer is a lot. We don't know a lot, and we're learning more and more every day. What people want to know is mortality rates. They want to understand how deadly this virus is. That's what we're seeing in the media. That's what you're seeing all over the place, is how deadly is this virus? How scared do we need to be? And we have estimates, and we love to report numbers and percentages. We can certainly look at different areas and extrapolate data and do the best we can to estimate. But the reason that we do not know this number is because we don't have a true denominator for these rates. We don't know how many people are actually infected with SARS-CoV-2, and so we don't know what the mortality rate is going to be. The case fatality rate, which is what everybody wants to know, is the number of patients infected with the disease that will die. So I'm going to repeat that. The number of patients infected with the disease. You can only get that number if you test people and you have them come back positive. So you actually have to have a reliable, consistent testing to know how many people have the disease in order to know how many people with the disease will die. We know pretty solidly how many people are dying, but we don't know what that denominator is. We don't know how many people are infected. And that's why this number is all over the place when we try to actually estimate the case fatality rate. Here's some case fatality rates for comparison, again, of some diseases that we do have a fairly reliable understanding of. Measles, well, remember that R0 was very, very high. The case fatality rate is actually quite low, 0.2%. Smallpox has a case fatality rate of 30%. SARS-CoV-1 had a case fatality rate of 10%. The 1918 pandemic strain of influenza had a case fatality rate of 10%. And then MERS had a case fatality rate of 35%, but that lower R0. So you can see how these numbers can kind of play into each other. So COVID-19 or SARS-CoV-2, what's the case fatality rate? We don't know. As I mentioned, testing is a big question mark right now, and we'll talk about that in a little bit. But we think it's somewhere between 0.5% and 3.6%. This is a map from the World Health Organization that shows the confirmed cases of COVID-19, and this is as of the March 9th, 2020. The bigger the red dot on this map, the more confirmed cases there were identified in that area. So the bigger the red dot, the more reliable the data will be to calculate a case fatality rate. So as far as testing goes, we're really looking to places that are doing widespread testing so that we can make accurate calculations. There's two purposes to this slide. One is that when I first made my slide deck, I had this situation report put into my slide deck, and this is from March 8th, and it was the globally the numbers that we had of confirmed cases and confirmed deaths, both globally in China, and then separating out between in China and outside of China. This is already completely out of date. So globally, as of this weekend, the case fatality rate was 3.4%. In China, it was 3.8%, and outside of China, the case fatality rate was 2.3%. This is all completely out of date already. So now, these are a new situation in numbers from the World Health Organization. And globally, our case fatality rate is now 3.6%. China's 3.9%. And outside of China, it's 3%. So these numbers are changing every single day. As we get more testing done and as we can calculate and we get more information from the different countries that are experiencing outbreaks, we will have more reliable numbers. But these, again, you can only calculate a case fatality rate if you have a laboratory confirmed case of COVID-19. So it's safe to assume, right, that there's a number of other people out there that got a cough and a fever and didn't feel well and stayed home for a couple of days or a week and then felt better and then resumed their normal day-to-day that never interacted with the healthcare system. They never called 911. They didn't go to the emergency department. They didn't go to an urgent care. They just, I don't feel good, stayed home, and then went back to their normal day-to-day. Those people are not calculated in any of these calculations because we don't have tests from them and we don't have a way to factor them into the calculations if they never actually interact with the healthcare system. So our hope is that there's actually a lot of those people out there and that these numbers are overestimates of what the case fatality rates are actually going to be. So this chart shows kind of where, it's just a visual representation of what we already talked about with numbers, which is where we think the new coronavirus is going to fall. On the x-axis is that R0, we talked about the average number of people infected by each sick person. And on the y-axis is a logarithmic scale of the case fatality rate. And we think that this novel coronavirus is going to fall somewhere within this vague orange box. But you can see here that measles is low on the fatality on the y-axis, but high on the R0 scale, whereas MERS is very high on the fatality rate, but lower on the R0 scale. So we're still trying to figure out where COVID or SARS-CoV-2 is going to fall somewhere in here. But this is why this is all in the stuff that we don't know heading. The other important thing to remember with case fatality rate calculations coming out of the World Health Organization, and this is out of the Chinese Center for Disease Control, is that it matters what your underlying conditions are, and it really does matter how old you are. So we're finding that the case fatality rates, the percentages of fatalities in China for people over the age of 80 is pushing 15%. Whereas people under the age of 49 is significantly less than 0.5%. So remember, when you calculate a big case fatality rate that encompasses all of the population, it needs to be broken down by age and by comorbidities. And so it's important when you're looking at these numbers to know that that's overall an average of a general population, but it really does make a difference what your comorbidities and what your age are. So why don't we know these things? We're going to talk a little bit about testing here for a minute. We need to have those robust numbers. And so this is, as of last night, the most current up-to-date guidelines from the CDPHE, or the Colorado Department of Public Health, for who we can test here in Colorado. So these are the guidelines that we're following. And these are read as someone that has clinical features and an epidemiologic risk. So you have to have both. You cannot have either or. You have to have the clinical features and an epidemiologic risk. So the clinical features here are, I'm not going to go through and read all of these, but the clinical features, and I think the CDPHE switched these boxes, but are essentially fever, signs and symptoms of a lower respiratory illness like we've discussed, such as cough or shortness of breath. And this fever can be measured or subjective, but this means that if you don't have a cough or shortness of breath, if you have a runny nose or a sore throat, you're currently not going to qualify for testing for COVID because we are finding that this is a lower respiratory illness. And then again, you have to have the epidemiologic risk as well. So these are people who have a close contact with somebody that has known COVID. So if you have a fever and a lower respiratory illness, but you don't have any close contact with someone with COVID, or you don't live in a nursing home, or you haven't traveled anywhere recently, et cetera, you're not going to be able to be tested for COVID. Now, I will say that travel and the contact are some of the areas that are constantly changing. So the history of travel to areas with ongoing community transmission within 14 days of symptom onset, this is a moving target. This weekend, the travel history only included international travel to the areas such as Iran, Japan, Korea, China, and Italy. But this is now starting to change as we're seeing more community spread in different parts of the United States. And I anticipate in the next 2 to 3 days that this will include domestic travel. But as of right now, it only includes international travel. And that's as we're trying to figure out which areas can classify as actually having community spread. This is the second page of the testing requirements. Important things to point out here are if you live in a nursing home, as I mentioned, or you are immunosuppressed and have symptoms, lower respiratory symptoms or a fever, then you will qualify for testing. And this is the map as of last night of the places with widespread sustained transmission and community spread. And community spread is another term that's important to understand. It essentially means that people are testing positive for the disease within their community without knowing where they got it from. So in the very beginning stages, you can say, oh, well, I was in a meeting with so-and-so tested positive for COVID, and now I have symptoms, and you know where you got it. Community spread means we're now seeing people test positive, and they don't know where they got it. Now, that doesn't mean it's necessarily more widespread. It could be that they got on the RTD bus right after somebody sneezed all over the railing, put their hand on the railing and touched their mouth. They don't know the person that sneezed on the railing, but if they then test positive and say, I have no idea where I got it, then that community is going to be labeled as an area with community spread. So it's just a term that tries to encompass the increased number of infections without being able to draw a line as to where the virus came from. So what can we do? And I want to spend some time here. I was planning on having a show of hands of the people that have seen this graph before, but there's a couple. Hopefully, virtually, a lot of people are raising their hands. I think there's actually a hand raise button on the Zoom, so if you guys want to click that, that'd be kind of fun. We know from countries and from outbreaks and from history that there is something we can do to try to help flatten the curve. So if you've heard the term flatten the curve, decrease the peak, etc., this is the graph that people are talking about. So this is a graph that shows representation of what a pandemic can look like. And what you don't want to be is the purple graph. What you do want to be is the blue and purple diagonal graph. So the purple graph is what happens when there are no community measures taken, a virus is introduced to a community, and everybody gets sick at the same time. And what happens when everybody gets sick at the same time is that the healthcare system gets completely overwhelmed. EMS gets overwhelmed. The hospitals get overwhelmed. The ICUs get overwhelmed. All of a sudden, you're having conversations like they're having in Italy, which is, who do you take off the ventilator to try to give a ventilator to somebody else? When somebody calls 911, who do you respond to? Do you respond to the college dorm that has 10 people that are coughing and febrile, or do you respond to the car accident with a potential fatality? You have to start making these hard decisions if you don't flatten the peak, because the healthcare system gets completely overwhelmed if everybody gets sick at the same time. And remember, day-to-day operations are still happening in the background of all of this, right? People are still having STEMIs. They're still having strokes. They're still wrecking their cars. There's still trauma. They're still fighting each other. They're still getting drunk at bars and falling off of stools. And so things are still happening in the world. And then you put this on top of it, and you can see how that very quickly would overwhelm a healthcare system. And that's what Italy is fighting right now. So you need to spread out the peak. And what happens when you spread this peak out, what happens when you flatten the curve, is you're spreading out the number of infections over time. And whilst a number of people are still getting infected, as long as they're all not getting infected at once, the healthcare system can hopefully absorb the needs and the demands that the virus or pandemic will place on the healthcare system. Because if you're able to get people better before you then result in getting another wave of people sick, then you can still provide this exceptional and quality care that people deserve to get. So what can you do to spread out the curve and to flatten that peak? There's a lot of things you can do, and we'll talk about a few of them. Voluntary home isolation. Introverts, we are so excited, right? We finally have society's blessing to just stay home. You cancel the plans you didn't want to go to. Don't go to the dinners. You know what? I can't go to the gym. I'm doing my part to flatten the curve. So those are things that you can do. Respiratory etiquette. This seems silly, but cough in your elbow, and then wash your hands or change your shirt. And then cleaning these high-touch surfaces that we've talked about. And then community measures, and this is what we're reading about. And this is also evolving very, very rapidly, but closure of childcare facilities and schools. If you remember the graph where it broke down the case fatality rate by age, you may have noticed that 0 to 9 years old, there was nothing. There was not even a tiny blip of a line. So what we've seen so far is that kids can get infected with SARS-CoV-2. They can get COVID. They get maybe a little sick, but probably not. But they're basically just cuter versions of the bats. So they can get the virus, they can spread the virus, but they're not getting sick. So that's the reason that people are talking about child care facilities and schools shutting down. It's not so much because we want to protect our kids, which of course we do, but it's because we're trying to flatten that curve. And then social distancing is why we're all watching this remotely, right? Changing your mass gatherings. Don't get a bunch of people together in one room at one time in the middle of something like this. Because all it takes is one cough or one surface or one sneeze, and then you have one other person infected that then infects 2.2 others, that then infects 2.2 others, and all of a sudden you're in that purple curve. And so getting everybody together at meetings or at conferences has significant impact, and it can make you fall into that purple curve instead of into that diagonal curve. So these are all things that we're trying to do to flatten the curve. Now, as a young, healthy person, if you get COVID-19, you probably are going to be just fine. But if you live with someone over the age of 60, if you are someone over the age of 60, if you have comorbidities, you may not be. And so it's one of those very challenging things where it's like, well, I still want to go about my daily life because I'm young, I'm healthy, I'll be fine. You will be fine. But we need to flatten the curve as a society. We need to do this as a group, and we all need to do our part to try to help our community. And that's where a lot of this is coming from. So work from home if you can. I anticipate none of you can because we're all frontline healthcare providers. And we'll talk a little bit about what we can do. Alternative care sites may be coming down the pipeline. So at the state level, we're always trying to plan and disaster preparedness to figure out that if we do get completely overwhelmed as a healthcare system, where can we take care of people? Fairgrounds, big rec centers, things like that. What can we convert into a place to take care of patients that have COVID-19 or take care of patients that have other illnesses if the hospital is full of people with COVID-19? So always keep an eye on what's happening, especially in the EMS world, because there may be alternative transportation sites, alternative care sites, alternative testing sites that will be popping up depending on how we do with our curve. If we flatten the curve, hopefully we won't have to do this. That's a busy slide. I broke it down. Denver Metro EMS physicians, we recently put this protocol. It's up on the webpage, so you can access it there. But we are implementing some changes as a group to try to help protect our frontline providers. We're trying to help protect our healthcare providers and our EMS providers. So this is Protocol 2070 for COVID-19 screening. It starts with a change in the PSAP and in the dispatch screening questions. So the cards for breathing problem and sick person on the EMD protocols will try to catch some people that potentially fall into the high-risk category in order to notify our EMS providers before they get to that person. So if there's a positive screen from one of the breathing problem or sick persons via a travel screen or a positive COVID contact, then one provider should enter in full PPE and assess the need for additional resources, of course, if the scene is safe. But if dispatch identifies a positive screen, then just one person should be putting on their full PPE, which we'll talk about in a second, and go in and initially assess the scene and see who else they need. So this is a little bit different than the whole fire crew or both people from the ambulance going in initially. This is trying to minimize the impact on our pre-hospital providers. You guys will have to decide who draws the short straw, rock, paper, scissors, or something like that, as far as that first person that goes in. We'll talk a little bit, too, about avoiding aerosol-generating procedures here in just a few minutes. The dispatch changes are obviously going to miss people, and especially as community spread becomes more of an issue. So if there's a negative screen initially, you have to rely on your own assessment of the patient to determine if they're a potential exposure. Obtain your own history and ask for clinical signs and symptoms and travel history. Try to limit, again, the number of people that are initially in there for that first contact. If you can safely stand 6 feet away from a patient and toss them a surgical mask, as silly as that sounds, that's one of the best things you can do to protect yourself. Remember that picture of the guy and all of the crud coming out of his mouth? If they have a surgical mask on, if the patient has a surgical mask on, those droplets are not being expelled as far, if at all. And so that is one way to very, very, very reliably protect yourself. So put a surgical mask on the patient. And then you want to screen the patient yourself. Do they have a fever, subjective or measured, or symptoms of an acute respiratory illness, cough, or difficulty breathing? If the answer is yes, then we're going to talk about PPE. So this is changing. I know Denver Health recently is, I think, dropping their N95 requirement. I think other institutions are close behind because we are identifying this as a droplet virus, not as an airborne virus. Eye protection is very important. Glasses are not sufficient. You need either a face shield or goggles. It's still in the protocol right now to put on an N95 respirator mask or higher, or a PAPR. Gloves, because of the surfaces. Disposable gown. Stay 6 feet away, as I mentioned. Toss them a mask if you can, or if you can't, go up to them and put a mask on their face. And then try to avoid the aerosol-generating procedures, such as suctioning, CPAP, BVM and advanced airways, intubating, nebulizers, unless they're in respiratory failure. So really try to make sure that we're not doing these procedures unless the patient absolutely has to have these things done. Because I know in a lot of the EMS rigs, the nebulizers are the little bit of the older versions where they're rebreathing, and then they're also, as they exhale, the nebulized particles are going to go everywhere. And in the hospitals, they have the one-way valve, but a lot of the pre-hospital nebulizers do not have a one-way valve. And so you really want to avoid nebs if you can. And then make a decision whether or not you're going to transport. This is another thing that's going to be changing. So there's a possibility that there will be either non-transport or alternative transport sites, as I mentioned, and non-transport protocols that will be written in that will basically say if they screen positive but they're okay and they meet all of the criteria, can you leave them at home? But if you are going to transport them, which as of right now we're still doing, you want to notify the receiving facility as soon as possible so that the hospitals can prepare and open up the rooms that they need to open up. If you're the driver and you have an isolated driver compartment, you want to take off all of your PPE prior to entering your driver compartment so that you're not transmitting the droplets onto those surfaces. If there's no isolated driver compartment, if the two compartments are connected, then you want to doff your gloves, gown, and face shield, but leave on your respirator to try to protect you from particles that are potentially coughed through the ambulance. The aerosol generating procedures to avoid, again, if possible, and this is from the CDPHE, are listed here. I don't think you can avoid CPR. If somebody needs CPR, you should probably give them CPR, but it technically is an aerosol generating procedure, so just use extra caution and wear your PPE if you're doing CPR. Turn on your HVAC system and perform as much as you can in an open space with open back doors of the ambulance before you transport. Turn your fan on to non-recirculating mode if this is an option in your rig that maximizes the air changes. Activate your rear exhaust fan and keep your pass-through closed if you have the option to close it off. If you have an open pass-through in your rig, you want to keep the front vents on full blast and the rear exhaust fan on, and that's going to create as much as you can a negative pressure process going through your rig. And then you want to notify the facility again that you're coming in. And then when you get to the hospital, you want to keep the rear doors open after arrival to allow for airflow changes, to allow that air to circulate, because that's one way to clear the virus out of the area. And then when you go back in to clean, you want to do all of your PPE once again and use the commercial products that are available to spray everything down or to wipe everything down. Don't shake your linens when you do that big thing before you make the bed. Hannah, do you have a question?
Love microphones, but do our cavity wipes or our purple wipes kill this virus? Do we know? Like off of surfaces? Like, do we need bleach wipes?
Sorry, I'm going to be honest, I couldn't hear you.
Do our purple wipes kill the virus?
Yes.
Okay.
And so what do you do if you're exposed to the virus or to a patient that you think has the virus? You want to notify your supervisor on duty, and they'll make the decision coordinated with the public health department. So pandemics like this are very interesting because while we strictly do follow HIPAA on a day-to-day basis, things get a little bit in the gray zone when you're dealing with a pandemic. And a lot of the testing, the monitoring, and the surveillance is going to be coordinated with the public health department. If you are exposed, the most important thing is to monitor yourself for symptoms. So if you're symptomatic, stay home, self-quarantine, and notify the public health and on-duty supervisor that you're symptomatic. These guidelines are also changing day to day because if we don't do enough to flatten the curve and we end up in the purple part of this pandemic, then we're going to need every single person that we have to try to work, right? And people are going to get infected, and they're going to be quarantined, and they're going to have to stay home. And so the quarantine requirements are going to change depending on the burden that all of this is going to initiate on the healthcare system. So always keep your ear to the ground for changes that are happening there. And for goodness sake, wash your hands. Keep calm and wash your hands. I hope this helped demystify a little bit of this for you guys. I think that we all need to be aware. We all need to do our part as a society and as a community to flatten that curve. We certainly don't need to panic, but we need to arm ourselves with the right information, with accurate information, and with good information to try to move forward and get through this together.
Okay. So I do have a few questions.
Okay.
First question I'm going to ask, someone is asking, where are the written Denver Metro protocols so that people can always go back to and refer to protocols?
The Denver Metro protocols, they're available. The easiest way to do it, honestly, is just to Google Denver Metro EMS physicians or DMEMSP protocols, and it should be one of the first or second things that pop up, and you can actually click through any of the protocols that we publish as a EMS physician group.
Someone was asking if you can put the CDC links back up again, please. Sorry.
So which slide?
The links to CDC. And while you're doing that, I'm going to ask another question.
Just a specific, okay. The links to the CDC.
Someone's asking, is there any data so far about post-mortem care? So patients who've passed away, do we have any contamination rates post-mortem?
That's a very good question. We don't have a lot of data there yet. However, since it is becoming more confidently accepted that this is droplet spread, unlike when we think of Ebola and some of those outbreaks, if it's postmortem, they're not actively expelling any droplets as long as you're wearing PPE and you're not doing anything that would potentially disrupt the virus from the respiratory tract. It should not be nearly as transmissible. Is this the slide they were hoping for? This is the CDPHE testing guidelines.
She has not sent me a text back, so I don't know. Someone's asking, how many ventilators does UCH have? What is the capacity here at university for patients that need vents? And then are there other pieces of equipment that would result in a elimination if the peak is lowered? I don't know.
Okay. Very good questions. I don't know the exact number of ventilators that we do have here at UCH, but I do know that one of the reasons that the state of Colorado declares a state of emergency early on in something like this is so that we can mobilize additional resources to get them if we need them. So I think there was a lot of backlash. People are saying, why were we in a state of emergency? We only have 18 confirmed cases in Colorado. And actually, the government declaring a state of emergency allows for us to ask for additional funding, additional ventilators, potentially military assistance, and they have a number of ventilators and funding and resources and personnel. So declaring that state of emergency basically trips us onto a disaster planning and preparedness track that allows us to expand our capabilities as a system. As of right now, we have 4 or 5 different ICUs, all with ventilator capabilities. And if, depending on where we fall on that peak, we should be able to handle a large number of critical patients. We're going to have to juggle that, obviously, with the patients that are already in our ICUs and the patients that typically need those resources on a day-to-day basis.
Someone is asking if they have already tested positive for this virus. Does that make them now immune to this?
We're still learning about that. Similar to other coronaviruses, it will likely, even if you're not fully immune, it would likely decrease the severity of infection were you to get exposed to this virus again. So it will also matter how the virus changes and morphs over time, but like with influenza, typically with the vaccine, or if you get influenza 1 year, your body's at least seen some version of that virus, which is why you may not have as bad of a case if you get infected the next year. So it's important. That's why the novelty of this is so important, is because it is a virus that none of our bodies have actually seen before.
Are patients who are immunosuppressed at a higher risk of being in danger of being once they are exposed to this, and or patients who take medications that do the exact same thing in terms of...
Immunosuppressed patients are significantly higher risk of severe outcomes and worsening clinical outcomes from this virus for the same reason that they would be with contact with any other infection. There are a number of different treatments and antivirals and things that are being studied and in the works, and real-time trials happening mostly throughout Europe right now, in China and in South Korea. We don't have anything for sure that we can say decreases the duration of the infection, or anything for sure that we can say improves outcomes.
Is there a community spread explanation for Italy? Like why Italy?
Really good question. A lot of places or a lot of studies right now are comparing Italy to South Korea. South Korea's reported mortality rate is like 0.6, and Italy's is very, very high, and their healthcare system is overwhelmed. The one thing that people are pointing to is that South Korea has a bit of an infrastructure and a government where they were able to shut things down very, very early. And Italy was a little bit behind that activation of some of those measures of quarantining, of social distancing, et cetera. And so they got started on that exponential increase, and it was too late by the time they recognized the community spread. The conversations right now is that if we keep doing nothing, we're about 8 to 10 days behind Italy. But if we keep working as we are really, really hard for social distancing and isolating and quarantine, we hopefully will fall more towards South Korea. But we think it's partly because Italy, one, they do have a little bit of an older population, but they also were unable to do a lot of the community-wide implementation to decrease community spread in time.
Should people cancel their vacations for taking a break for just random things currently? People are asking about going to the mountains or staying in hotels, things like that. Should that be canceled over the next upcoming breaks?
It's a tough question, right? It's spring break time. A lot of people have vacations planned. It's hard to say exactly where this is going to go. The advice that I've been giving friends and family members that ask me the same question is the safest thing to do is cancel your travel plans. And that includes driving to the mountains and going to areas where there's large groups of people. Now, skiing, everyone's masked and out in open air, so in theory there shouldn't be a whole lot of transmission there. But if somebody coughs on their glove and then puts their glove on the chairlift, and then for some reason you're checking your phone and you put your hand there and don't have your gloves on, sure, in theory you could get it. It is, we're starting to see clusters in our Summit County and in our mountain towns. We're starting to see clusters of outbreaks, and that's because there's a lot of people in one area at one time. So as far as a flattening the curve answer, yes, I would say cancel your travel plans. It's the right thing to do for the community. But you obviously have to make that decision and what's best for your family depending on how essential the travel is.
A patient tests negative for flu A and B. Can they still test positive for COVID-19?
We're seeing a very low co-infection rate of COVID-19 with other viruses, so the respiratory viral panel, which includes influenza. It also includes a lot of other coronaviruses, as well as rhinovirus and some other common cold-causing viruses. We're seeing, I think it's less than 0.2% co-infection rate. So if somebody tests positive for influenza A or B, it's very, very, very unlikely that they are co-infected with COVID.
If a person tests positive and is in self-quarantine for 14 days, can we presume that after that time period, their rollout decreases and will they infect others, or will they be safe to be?
So 14 days is the magic number that we've picked to keep people in quarantine if they test positive, with the caveat that they're completely symptom-free at day 14. So if someone's still febrile and coughing, or coughing and sneezing at day 14, that quarantine needs to continue. But technically, at the 14-day mark, if they have had no coughing, sneezing, or fever, then they would be safe to come out of quarantine. We're still figuring out if there's viral shedding after people are asymptomatic, and some of that is because we're not testing people that are asymptomatic, so we don't know. There was one study that was published in JAMA from a large population in the province of China, where they tested a very large amount of completely asymptomatic people, and they found that a fair amount of them still had a very large viral load in their blood, but they were unable to transmit that virus to other people. So, did you have a question? So the question is, if you develop pneumonia, where are we going to see that? So the incubation period, we think, is about 2 to 5 days for the virus itself. And as far as the cough and fever, the severe respiratory ARDS and severe pneumonias requiring hospitalization and ventilation, we're seeing around the 5 to 10 days after infection from the virus. After infection, after exposure.
That you had that depicted the outbreaks on a global level.
Mm-hmm.
I don't know if that was the WHO or CDC site. It looked like China was starting to identify recovery rates.
Mm-hmm.
Can you kind of speak on that? Because we're 3 months into this pandemic, and now they're starting to show recovery rates. Is that something we can look at as far as a time frame? In 4 months from now, could be reporting recovery rates?
Yeah, good question. I'll repeat it for those tuning in virtually. So the question is about recovery rates and how we're starting to see China report some recovery rates after infection. We're about 4 months into when they first identify the virus. And is that something that we can look to, and is that something that seems reliable? I think a lot of that has to do with their ability to monitor the people that they identified as positive. So I think they're seeing a recovery occur anywhere kind of from that 2 to 3 week range after a person is infected and asymptomatic. And then I don't know exactly how they're monitoring full recovery. But it's hopefully some of that really depends on where you land on the peak and where you land on the curve, because the recovery is going to happen faster if you can give people the additional support and oxygen and IV fluids and things they need in the hospital, as long as the healthcare system doesn't get overwhelmed. And it depends on the mortality rate as well. But we're certainly going to be looking to China and to South Korea, Iran, and Italy to see where these recovery curves start and if there's anything we can do to speed up that.
What are we doing to prevent exposure to ER workers when a patient has been in a room for an hour and the SARS or CoV-2 tests are added later on? This happened a few times earlier this week, where a patient was in a room for 2 to 3 hours, then the testing was ordered. So staff was possibly exposed. What are we doing to try and prevent exposure to staff?
Very good question. And how are we going to protect ourselves as healthcare workers moving forward? I think as this evolves, the safest thing, as I mentioned, is when we drop the N95 requirement, I think it's going to be a lot easier. But essentially, as a healthcare provider, and anyone that has a cough or a fever or any other complaint of the similar symptoms, it is a gown, gloves, and a mask until you have a positive flu test or until you have an obvious pneumonia or some other explanation for their symptoms. There's concern with the shortage of PPE, and if we're doing this with every patient, we're going to run out of PPE too quickly. Again, being in the state of emergency is a way that we can try to help mobilize resources. But until proven otherwise, our recommendation is that patients with these symptoms you need to wear at least a surgical mask, eye protection, a gown, and gloves.
Well, actually, I'm going to cut this short. I know that we have a lot more questions that I have not even asked, but because of time, I'm going to recommend if you have more questions, please shoot them through this chat system here if you're home or online, and we will do our best to try and answer some of those as well. And I'm also going to refer back to the link, CDC, for more questions. Like Angie said, this is still being looked at and updated every single day throughout the entire day. But because of time right now, we are going to cut this short as of right now. And I'm going to have everyone go to lunch. And we will see you guys back here at 1.
CDC, WHO, and CDPHE. Those are the 3 places you really should be getting all of your information from. Thank you, guys.